Good morning, everyone. We're just going to give everyone a moment or two to log on, and we'll begin shortly.
Okay, well, it's 9:02 and I think we can get moving. I want to welcome everyone this morning to the Weill Cornell Medicine and Melanoma Research Foundation Joint Symposium on Mastering Melanoma, a symposium for patients and caregivers. This is our agenda for this morning. We're just going to do some hellos and welcomes, and then we'll start the program. So I'm Dr. Anna Pavlik. I am a medical oncologist at Weill Cornell Medicine, and I would really like to welcome all of you this morning for joining us, and hopefully we will have an informative program for all of you. I also want to thank the MRF for partnering with us this morning to present this program. I'd like to turn it over to Dr. Wolchuk if he has any comments.
Thanks, Dr. Pavlik. Good morning, everybody. I'm wearing two hats this morning. I am first and foremost a melanoma oncologist, but also speaking to you as the director of the Meyer Cancer Center at Weill Cornell Medicine and New York Presbyterian. We are thrilled to have you with us this morning to provide what we hope will be useful information about melanoma diagnosis and treatment management. And as Dr. Pavlik said, we are really thrilled to be partnering with the Melanoma Research Foundation for this important program. We encourage you to ask questions, and also if there's any follow-up needed, all of our contact information for the speakers are available on the Weill Cornell Medicine website. So thank you very much again, and I'll turn the program over to Miriam for a welcome from the Melanoma Research Foundation.
Wonderful. Thank you so much. It is so wonderful to be with all of you this morning. My name is Miriam Kadosh. I am the Director of Education and Patient Engagement here at the Melanoma Research Foundation, and I am so grateful to partner with Weill Cornell to be with all of you this morning to give you an educational opportunity, a chance to connect with your care team, and to ask questions. To hear the latest in research, latest in treatments, and supportive medicine as well. So we are very excited to be partnering today. And I want to share a little bit about the Melanoma Research Foundation, what we do, and how we can best support you and the community. So I'm going to get started here. So a little bit of an overview. Before I get started, I just want to let you know that we will be having an evaluation at the end, and it will pop up at the end of the program today. So just make sure to look out for that. Feedback is so important to us. But first, I want to take a moment to thank our sponsors. We run many patient and caregiver symposia across the country each year, and we also run an adult and young adult and adolescent wilderness retreat and a pediatric patient symposia. And these are wonderful opportunities for patients to come together. But we want to thank our sponsors because we could not do it without their generosity. So thank you to all of them. And a little bit about how we got started, who the MRF is. We were founded around 27 years ago by a patient, Diana Ashby. And at that time, there were very few treatments available for metastatic melanoma. And when she was diagnosed with her third melanoma, there was no research that could potentially lead to a cure for her, and there were very little treatment options and no funders in this space. So she did not want to take no for an answer, and raised funds to fund research and brought together her family and friends to join her in this effort. And that's how the MRF was formed. So over time, our mission has evolved. And we were the first private funder in the space outside of the federal government. And I'll talk a little bit more about that. But as melanoma drugs have continued to evolve, and more FDA approvals, thank goodness, came about, our mission has changed and evolved as well. So our mission is a tripartite mission. And our mission is to eradicate melanoma by accelerating medical research while educating and advocating for the melanoma community. So I'm going to talk about all three just for a moment, so you can have a little glimpse into what we do. And I want to show you our footprint today. Our footprint today is national, although we are located in Washington, D.C. We're national. We are traveling all over the country to support patients. We work with advocates all over the country in their own communities, whether they're hosting an event or we're hosting an event, to be able to support and benefit melanoma research. In the middle, we have one of our 5K events, which is our Miles for Melanoma. We had 17 this year across the country. We had our New York City one last weekend, which was very successful, even in the rain. So wonderful to see a lot of you out there. But if you were not there and you'd like to get involved for next year, we'd love to have you. On the right, we have a lab tour at Moffitt Cancer Center. At the bottom, we have a patient panel. And then all the way on the left is our #GetNaked awareness campaign, which I will share a little bit in a moment. But Teddy Mellencamp from The Real Housewives, if you're a Bravo fan, is our spokesperson this year. So I will speak a little bit about our research grants. We have funded over $23 million to date in research since our inception. But one of the really unique things that I want to share with you is that we put patients at the center of all of our work. Patients and caregivers are involved in our grant review process. So we have patients review our grants and provide their insight, because, who else to give us feedback other than the patients who are receiving that important treatment. So this is a process that we do have open every year. So if you're interested in the grant review process, we invite you to please reach out and email us. We'd love to have you in that process and participate in the training and the grant review. We also have some scientific initiatives. We've hosted many different workshops over the years on issues ranging from brain metastases to rare diseases to adolescent young adult cancers to lethal melanoma. So a lot is going on in the research world, but we do a lot more as well. And as the Director of Education and Patient Engagement, I can talk a lot about our education program, which I am so proud of. You are all experiencing an education program here today, but we also have many more resources that we do have available in regards to our education program. We offer free webinars on different topics. That's once a month through our Ask the Expert webinar series. We have animated patient videos on our website. If you go to melanoma.org, these animated patient videos are 7 to 10 minute animations. They take very big, complex concepts and distill them down to a 6th grade reading level. And these are free. All of our programs are free. They're on our website. We share them with the physicians. We share them with dermatology offices, so that they can show their patients and their community. And we also have patient and caregiver guides that are available free of charge on our website. Not only that, we have many education literature materials that you can order for an event in your neighborhood, in your community. You can bring it to your children's school. We have specific ones for parents with children to learn about sun safety. And also We have programming for the rare melanoma subtypes as well, including uveal melanoma, mucosal, acral, adolescent, and young adult and pediatric. So lots going on the education front. As I spoke, we also have Ask the Expert webinar series, and we bring experts on a particular topic, as well as a patient perspective as well. So if there is a specific topic that you're looking to hear more about, an FDA approval, or any sort of treatment questions, side effect questions that you're looking to hear more about, advocacy even, we'd love to bring those topics to our patients and our patient community. So please be in touch with me. I'd love to get to know you more and meet your needs. So next, I'll talk a little bit about our advocacy efforts. I mentioned earlier, we advocate both on the state and federal level. So our advocacy program has a few aims, and first is research. So we advocate for research funding in this space. So this is through the Department of Defense. And because our advocates are so wonderful, they go to Capitol Hill for our advocacy days each year. It's coming up in March. So if you'd like to be involved at Capitol Hill down in DC, that would be wonderful. But we used to be lumped into rare cancers, and now, because of our advocates and the strong work that they did, we got our own line item. And at first it was $10 million, and then with lots of advocating, we are now at $40 million for melanoma research, which is an incredible amount of funding for this important mission. And they also have added a space for rare subtypes as well, which has been amazing. And it's great to have our advocates using their voice and sharing their story, telling lawmakers how important it is to fund melanoma research. So we also work on the state level. A lot of our work in prevention initiative is for state by state tanning beds and banning of tanning beds, which is very hard to regulate for minors under 18. So we're trying to work on that. We've been working on that for many years. And that is a huge piece of legislation that we're hoping that will go through for this federal ban on tanning beds for minors. So we're excited about kind of the movement there. And then the last piece is access. So access to clinical trials for patients, access to treatment centers, access for telehealth. A big piece of what we do is focus on educating the general public about melanoma. So we have multiple awareness and prevention campaigns throughout the year. And one being I spoke about before is our Get Naked campaign, #GetNaked. And this is encouraging people to go get their skin checked and see their dermatologist for a yearly skin exam. We even have skin check guides that we can provide to people, and we do skin checks at our 5K Miles for Melanoma events as well. We use real people to tell their stories so that we can change behavior. As I said, our spokesperson this year is Teddy Mellencamp, who is John Mellencamp's daughter, for people who might know them. And her big message is to not use tanning beds and to share to young women to love the skin that they are in. And beauty doesn't need to be bronzed and tanned. She had a tanning bed in her home growing up and has now had her, I believe, 12th melanoma diagnosis. Our next campaign is the #IGetDilated, which is encouraging folks to get yearly eye health exams and get their eyes dilated. This is the only way to detect uveal melanoma. And we do see that 2,000 patients in the US are diagnosed with uveal melanoma each year. So it's important to get a dilated eye exam for eye health in general. We also have our pediatric melanoma campaign, which is Spot the Dog. You'll see it on my slide. This is really targeted at pediatricians and parents. So with pediatric melanoma, it's a very rare form of melanoma, impacts around 400 to 500 children a year. Some may be genetic related and some may be UV exposure related. But this is just a way that we can connect with families and pediatricians to look out for for pediatric melanoma and support those patients. And lastly, our mucosal melanoma Out of the Shadows, which is a campaign, we like to say, for patients where the sun, mucosal melanoma happens where the sun don't shine. And these happens in the mucous membranes of the body. And so this is to bring awareness to the resources that are available for those patients as well. So I want to thank you all again, and for letting me be here today and speak about the wonderful work that we do at the Melanoma Research Foundation. We'd love to have you involved in any way that we can. Here are our social handles if you'd like to connect with us. We have a lot of resources that we'd love to share. If you can visit us at melanoma.org, that would be wonderful. And if you'd like to connect with me, my email is education@melanoma.org. We are so thrilled to be here today with Weill Cornell, with these wonderful, wonderful people who are doing such amazing things in the melanoma world, and leading the charge on research. And that is what we love to see. So thank you all. I will be here to answer questions, and to be a resource to all of you. And I look forward to a wonderful day. Thank you all.
Thank you so much. And we're going to move along with our program. That was just wonderful. The MRF really does have such an abundance of educational materials and are really such wonderful patient advocates. I have been doing the New Jersey walk, I think for the last, I want to say 20 years since it started, and usually get a team together since I do live in New Jersey. And I want to turn the program over to Dr. Kara Minkus. Dr. Minkus is a dermatologic surgeon at Weill Cornell Medicine, and she is going to speak to all of you about the basics of melanoma. Dr. Minkus, the stage is yours.
Great, thank you so much. Could everybody hear me?
Yes.
Okay, great, thank you. So it's a pleasure to be speaking to all of you today. And obviously, everybody who's on here already knows about melanoma, so this is going to be a very brief intro. But as you know, melanoma is one of the deadliest forms of skin cancer if detected late, and that's key here. So we'll talk about ways that we could recognize melanoma at its infancy or early on, and hopefully that will help to mitigate the risk of it progressing. Early melanoma is actually very curative, and we'll talk about treatment for that. And so early diagnosis and treatment are really crucial here. And there are some signs that could help us to be able to distinguish a benign mole from a melanoma. We use the mnemonic ABCDE as warning signs of melanoma that can help with early detection. Let's see, is my slide advancing? I don't think I could advance. Oh, wait, sorry. Okay. There we go. Perfect. Okay, so let's talk about melanoma diagnosis. So the ABCDEs are listed here. E is left off, but I'll talk about E as well. So A is for asymmetry. So here you'll see on the left-hand side what a normal mole would look like compared to a melanoma. So you could see with a normal mole, it's nicely symmetric. You could cut it down the middle, put a mirror there, and one side matches the other. Whereas with a melanoma, it becomes asymmetric. It extends, could potentially have a tail that extends in one aspect of the melanoma, and so one half does not match the other. B stands for border. So whereas benign moles have a regular, well-circumscribed border, melanoma, the border becomes jagged and ragged and irregular, and so sometimes it's hard to even know where the melanoma ends. C is for color. As you can see in the normal mole, you have a uniform color, whether it's dark brown, light brown, sometimes pink or skin colored. With melanoma, you start to have variegation in the color. So it could have parts of it being darker, parts of it being lighter. In this example here, you could see there's a dark brown, almost black component and a light brown component, and it could vary throughout. Other colors you can see are sometimes white, sometimes pink, almost a bluish type of color. So really quite a variety. And D is for diameter. So a regular mole typically tends to be small, although obviously there are exceptions to this. So if you have a large mole, don't freak out and start thinking that you have a melanoma right away. There are some moles that are very large in size, and that's normal. But particularly if there's any changes to the size, or if it is a larger lesion that you're unsure about, we talk about 6 millimeters being the cutoff, and that is approximately the size of a pencil eraser. And lastly, E, which is not on here, but it stands for evolving or changing. So if you have a mole that all of a sudden starts to change, starts to grow, starts to bleed, starts to develop any of these features here that we discussed about, that is a reason to see your dermatologist and have it evaluated. Okay. So how do we, as dermatologists, establish the diagnosis? So typically it's a clinical examination that helps to determine when a biopsy is necessary. Biopsy ultimately is what ends up allowing us to make the final diagnosis, but some of the features that we just spoke about help us determine whether a biopsy is even necessary. There is also an instrument called a dermatoscope, which is a handheld, almost like a microscope, that could be polarized or non-polarized, and that allows us to see a little bit deeper into the skin and have distinct features dermoscopically that help us to identify whether a mole is concerning. So here you could see on the right-hand side what some of the dermoscopic features might look like in a mole versus a melanoma. And there are various ways that we could biopsy the skin. So biopsy just basically means we take a little sample of it, send it off to the lab, and then the dermatopathologist is able to look at it under the microscope and establish the diagnosis. We have a shave biopsy, which is the top panel there. Just we take a scalpel or sometimes a derma blade or any kind of blade and kind of take a little sliver off the top of the skin. You could take a very thin sliver, or you could take a deeper sliver, and the deeper, sometimes we call it a scoop shave. The other option is to do something called a punch biopsy that's illustrated in the middle panel. And there it's almost like a cookie cutter type of handheld instrument that is very sharp. So it's essentially a blade that's in the shape of a circle, and they come in different sizes. And it allows us to take a deeper section of the skin. So we kind of punch out the skin. That's why it's called a punch biopsy. And usually with that one, it does require putting a few stitches in the skin. And then lastly, there is something called an excisional biopsy. So sometimes we do that if we have a very high concern that it might be an advanced melanoma. Then instead of doing a shave or a punch biopsy, we actually cut the whole thing out. And the reason for that is because we want to determine how deep the melanoma goes. We'll talk about why that's important as well. So this is what melanoma could look like. These, as you could see, all meet the ABCD criteria. So they are asymmetric, they have irregular borders, there's a variation in color. We don't have a ruler, but I imagine that these are all larger than 6 millimeters. So this is when I speak to many patients, this is kind of what they envision melanoma to look like. And that can be true, but this is a patient that I just saw, and with her permission, I decided to add this yesterday. I saw her this week, and you could see this melanoma really doesn't meet those criteria. So it's a little brown, but mainly it's pink. And these are the ones that really cause dermatologists to lose sleep at night, because they really aren't something that you walk into the room and are necessarily worrisome. And this patient has had this for a year now, and obviously did not look anything like the melanoma examples that I just showed you, but this ended up being an invasive melanoma. There's also a form of melanoma called lentigo maligna melanoma. So I should just say that there is not all melanomas are created equal. There's a variety of different subtypes of melanoma, and they have to do with the growth pattern, the location, the etiology. So certain kinds of melanoma, such as nodular melanomas, occur from intermittent sun exposure, whereas lentigo maligna typically occurs in heavily sun-exposed, chronic sun-exposed areas, so most common on the head and neck. These melanomas can also occur very slowly and go undiagnosed for many years, because as you can see in this patient here of mine, her melanoma kind of blended in a little bit with the background sun damage and freckling that she had on her skin. But this was a melanoma that actually ended up being much larger than it appeared. So this is her at baseline. This is after we had resected the melanoma. And the way that we remove these is by cutting them out. So we do something called a stage excision. I'll have a slide on that later. And then we reconstructed her. And although you could see she's missing a big part of her cheek, this is after her reconstruction, just 3 months later, and you could see she's smiling, she's doing great. So although this seems like, pretty morbid surgery, patients actually do pretty well with well-healed scars. This is another subtype of melanoma. This is acral lentiginous melanoma. Those type of melanomas occur in on areas such as the palms, the soles, and the nail unit. So you could see an example of this melanoma occurring on the nail here. We see this type of melanoma more commonly with darker skinned individuals, so patients of Asian backgrounds, Latino, Hispanic, and African American or Black patients. More common to have this type of melanoma than other types of melanoma. Similarly, based on its location and demographics of the patients that develop this type of melanoma, it oftentimes goes undiagnosed for a long time and can present at a later stage. Here are some more examples. You could see early on, they often present as just a streak in the nail. And then obviously as they progress, you have a larger, more prominent streak. You could also have what's called the Hutchinson sign, where the pigment actually ends up extending beyond the nail to the surrounding skin as well. And sometimes I've seen these misdiagnosed as fungal infections or other types of benign things. So it's important when we examine patients that we either ask them if there's anything under their nail or take their nail polish off if they have nail polish on. So again, just some more examples. You could see some melanomas look more pink. Some have areas of white. Sometimes that correlates with what we call regression, meaning the immune system is trying to get rid of the melanoma. These are, more classic pigmented melanomas. There are benign growths that oftentimes are the initial chief complaint that bring patients into the office because they appear sometimes very dark or irregular or large. And these are called seborrheic keratoses. There's lots of different other names for them, such as barnacles of age, but they are completely benign. They're not worrisome. Sometimes I call them over 29 spots because almost everybody above the age of 29 will have at least one of these. Some people are studied with them, and they're more of a cosmetic issue. We can get rid of them cosmetically if they are bothersome in their aesthetics, or sometimes patients are itchy from them, and so we could get rid of them by various different means, but they're completely harmless. But you could see where somebody that might not know better, they see a dark brown lesion on their skin and they start to get very worried. So we spoke about the different types of skin biopsies that we do, and I had mentioned that sometimes we do what's called an excisional biopsy or a punch biopsy, where we get a little bit more depth of the skin in sampling it. And the reason for that is because the skin biopsy determines the depth of the melanoma, and the course of action that we need to take, as well as the prognosis, is determined by this as well. So we talk about either the Breslow thickness or the Clark's level, and that just tells us in the pathology report how deep the melanoma extends underneath the surface of the skin. So if it's just on the surface of the skin in the first layer of skin, which is called the epidermis, then we call it a stage 0 or in situ melanoma. Those are kind of the most indolent, early stage, easier to treat melanomas. And then as they go deeper underneath the surface of the skin, beyond the epidermis into the dermis, then you could see the survival of the melanoma starts to decrease with stage and with depth of the melanoma. So how do we treat melanomas? So with early stage, either stage 0 or stage 1, which is less than 1 millimeter now, it's actually reclassified to 0.8 millimeters, but below, 0.8 to 1 is really what we consider early thin melanomas. And in those cases, surgery is really curative. We don't really even bring up in stage 0 and stage 1A, which is up to 0.8 millimeters in thickness, doing any additional studies, such as sampling the lymph node or any adjuvant studies. I'm sure there are some exceptions to that, but overall, that's kind of how we subclassify these. For thicker melanomas, there are additional studies that are required, additional surgery might be required, and systemic therapy might be required. And so again, to kind of subclassify who treats what, dermatologists or dermatologic surgeons tend to treat the early melanomas either in situ or stage 1A. And we treat them by cutting them out. So we do what's called an excision. The excision margin, which is the amount of normal skin around the melanoma that we take, is determined based on whether it's an in situ or an invasive melanoma. With an in situ lesion, the one that's the earliest stage on the surface of the skin, we take 5 millimeters or half a centimeter around. If it goes deeper, up to 0.8 millimeters in the most recent reclassification, we take a centimeter around it. Deeper melanomas get referred out to our colleagues in otolaryngology or surgical oncology. So here's what a fusiform or elliptical excision or wide local excision would look like. You could see here on this patient's neck, there's a brown macule, we call it, and that's the melanoma. And there is a margin of normal skin drawn around the melanoma. It's actually extended with those little cones or triangles on either end so that we could then stitch it in a straight line. And then we put stitches in several layers, and typically it heals with a fine little linear scar. So this is what we would do for either an in situ or an invasive melanoma. The outer circle, the size of the outer circle would be determined based on the thickness of the melanoma. For lentigo maligna, we typically do what's called stage excision. So the main difference there is, unlike the standard elliptical excision, where we draw out the ellipse and then bring the edges together in a straight line, here we remove the melanoma in typically 3 to 5 pieces, as illustrated here. And the reason is we want a lot of precision in terms of determining whether or not we got everything out, and if not, where we need to go back to take more. These type of melanomas do tend to be larger than they appear. So rather than stitching it up and keeping our fingers crossed that we got everything, oftentimes the reconstruction or stitches, as I showed you in the earlier example of my patient, could be much more complicated than just a straight line. And so we don't want to proceed with the reconstruction until we have confirmation from our pathologist, what we call histologic confirmation, that we've gotten everything out. So we usually remove it. We mark some of the quadrants so that the pathologist knows precisely where we need to go back for more and could report on that. And then if necessary, the patient comes back, we go back to the area where there's still melanoma extending to the edge, we take more, and that process continues until we get clear margins, and then we proceed with the reconstruction. So there's that same patient that I showed you earlier, and you could see how much larger that ended up being. Okay, so now I'm going to shift gears a little bit to talk about how do we prevent melanomas. And this is actually true for non-melanoma cancers as well. So I'm a Mohs surgeon. I do a lot of Mohs surgery for treatment of non-melanoma skin cancers as well. And so this is, not just to prevent melanoma, but in general to help you prevent sun damage to your skin and development of any kind of skin cancer. So number one thing is seek shade when appropriate. So the strongest rays are between the hours of 10 a.m. and 2 p.m. When I give this, not this talk, but when I talk to kids in school, which I do every year, I usually tell them, if you don't know how to tell time, look at your shadow. If your shadow is shorter than you, seek shade. So that's a quick little trick. Wear protective clothing. I'm a huge fan of some protective clothing. I think I have a slide on this later, but there are some companies that create UPF clothing. There's also hats that have sun protective factor in it. So that's something that's just much more consistent and take some of the work out of your hands. So you don't have to worry so much about what sunscreen to use, how often to reapply it, etc. You want to be extra cautious near water, snow, and sand. A lot of my patients I see getting sunburned in the wintertime because they don't realize how much sun you actually get when you're skiing, for example. You're on the snow, you have reflection from the snow. You're also usually at high altitude on a mountain, and you could really get a lot of sun. So just, something to be aware of. Avoid tanning beds and perform regular skin exams, and then also obviously see a board certified dermatologist for your skin exams. Our recommendation is if somebody was diagnosed with a melanoma, for the first 2 years after diagnosis, we recommend seeing a board certified dermatologist about once every 3 months to get a full skin exam or total body skin exam. After that, it's twice a year. And then if you don't develop any new non-melanoma or melanoma skin cancer, then you could go back to annual skin exams. We also recommend first-degree relatives be examined because there is a familial predisposition to melanomas as well. And so if any first-degree relatives have been diagnosed with melanoma, we recommend they be screened as well. So some protective clothing is usually lightweight, and they come in all different kinds, but you have long sleeve shirts, sleeves themselves, if you want to just wear them with a t-shirt, pants, wide brim hats, and sunglasses. And then sunscreen use. So this is something that we definitely emphasize with all our patients. This can help prevent both skin cancer and premature aging of the skin and photo aging of the skin. So we recommend SPF 30 or higher. You don't have to get SPF 100. The key is appropriate use, which we'll talk about here. So you want it to be broad spectrum, and that's something that the FDA now requires be placed on the actual bottle. So you'd see it listed. And what that means is that it protects against UVA and B rays. You want to apply generously about 15 minutes before going outside and use a sufficient quantity and reapply frequently. So quantity-wise, for an entire body, you would need basically a shot glass full. So you could see here, 2 teaspoons, what that would look like, 1/4 of a teaspoon, etc. So basically, you would need a shot glass full each time that you apply if your entire body is exposed. And we recommend reapplying every 2 hours. So you're going to go through that sunscreen bottle very quickly. And the biggest flaw I see and hear from friends, patients, etc., is somebody goes for a 1 week, beach vacation. They bring 1 bottle of sunscreen, and that lasts their entire family for the week. They're clearly not using sufficient amounts. And when they come back, if their skin is burned or suntan, they'll say, well, but I use sunscreen. It's just, this is how my skin reacts. It's not about using it. It's using the right amount and reapplying it. So again, I spoke about this already. FDA requires listing on the bottle whether it protects against UVA, B, or both, and broad spectrum means both. Just to let you know, UVA is implicated more in skin aging, whereas UVB is more implicated in skin burning. And then you could see here how the SPF factor determines how much of the sun's rays actually penetrate and enter into the skin. Are there such things as waterproof sunscreen? Not really. So there are some sunscreens that say, you know, water resistant on it, and they used to say waterproof, but really what that means is how long can you be in the water when you put this on? So you have water resistant and very water resistant, and basically that means that you could be in the water for about 80 minutes without the sunscreen washing off, but you should still reapply afterwards. So either 40 or 80 minutes, depending on what it says. So water resistant is 40 minutes. If you get very water resistant, it's double that, so 80 minutes. But you could see, you know, 80 minutes is still, you know, significantly under that 2-hour reapplication time that we normally recommend. So somebody who's in the water all day is going to have to reapply constantly, or you know, my recommendation, what we do in my family is just wear some protective clothing, because then you don't really have to worry about the sunscreen washing off or reapplying constantly. The sport sunscreens will essentially be the water resistant ones. So you'll notice that if you get a sport sunscreen, it'll usually say very water resistant, which basically means that you could be in the water for 80 minutes. So why reapply? Because it washes off. So either from towel drying or sweating, being in the water, etc. And then here's another question that I often get is the difference between physical sunscreens and chemical sunscreens. So the physical sunscreens are zinc oxide or titanium dioxide. They reflect the UV radiation away from the skin, whereas the chemical sunscreens, they absorb the UV radiation before it can penetrate the skin. The physical sunscreens are the ones that are in the sunscreens that are marketed for either babies, children, or sensitive skin, because oftentimes if somebody does have a allergic type of reaction to sunscreens, it'll be from the chemical active ingredients. Sunscreen is safe. There have been some controversial studies that have shown in laboratory animals at 300 times the concentration that a human will ever use in their entire lifetime, that it can cause some problems in laboratory animals, but there's been no evidence to date that this is true in humans. And there are many reef-safe sunscreens as well. So, you know, that's another reason why some people are hesitant to use sunscreens, but there are many that actually will say reef-safe on them. And lastly, skin cancer detection is something that all of us could play a role in. So in addition to seeing your dermatologist, it is important for you to also do self-skin exams. If you go to the American Academy of Dermatology website, they will have this body mole map there, I believe. And it kind of reviews what we spoke about here, the ABCDEs of melanoma, things to look for, how to do a self-skin exam. Don't drive yourself crazy doing this every single day, but certainly something once a month after the shower you can do, and just look yourself over, record anything that looks concerning to you, and then you could present that to your dermatologist when you see them. Again, just reviewing A for asymmetry, B for border, C for color, D for diameter, and E for evolution. Indoor tanning, I'd mentioned, also something that we recommend avoiding. There's a 59% increase in the risk of melanoma. And now the AAD, the American Academy of Dermatology, lobbyists have really lobbied strongly to try to restrict access to indoor tanning. This was something that really was very unrestricted. Kids, teenagers, sometimes even middle school kids would be able to go to tan without even parental permission. So we're really working hard to change that, and with a lot of success. So the piggy said to the bacon, maybe next time you'll try a little sunscreen. And then these are just some photos of what a dermatologist looks like at the beach. Thank you.
Thanks, Kira. That was really amazing. Great overview, lots of helpful hints. I now welcome
Hey, wait,
anyone.
we do have a few questions here in the Q&A section. So someone is asking, what is your opinion on spray sunscreens? Are they effective as lotions for the body?
That's a great question. So they're very popular. I could tell you, even in my own family, my kids much prefer the sprays, even my husband, to lotions and creams. That being said, they're very inconsistent. And the reason is that most people, we spoke about quantity and how quantity actually impacts the sunscreen, the SPF that you get on your actual skin. And with sprays, most people just do a very thin layer, don't even rub it on. With some sprays, like the clear sprays, you can't see where you actually applied it and where you didn't apply it. So you could end up getting a very streaky kind of burn or tan. So while they're better than not using sunscreen, I would just caution you that if you are going to use it, to make sure you get an adequate amount, you get good coverage, rub it in to make sure that everything is covered. Make sure if you could get somebody to assist the hard to reach areas, that would be, preferable.
Perfect. And we have one more here that says, are active ingredients in European sunscreen superior to sunscreens approved in the US?
Yeah, great question as well. Yes. So there are sunscreens that are effective, but not FDA approved. So there's a much wider range of great available sunscreens in Europe than there are here, because the FDA really very strongly regulates sunscreens that come on the market here. So I would say the answer to that is yes.
Perfect. Thank you so much, Dr. Minkus.
My pleasure.
And I will turn it back over now to Dr. Pavlik.
Very good. And again, thank you so much, Dr. Minkus. I think that was really an excellent overview of the basics of sun safety and early management of melanoma. So thank you. And so with that, we're going to move forward with our next speaker, who is Dr. David Cutler. He is a surgical oncologist in the Department of Otolaryngology at Weill Cornell Medicine. So he is a head and neck surgeon, and he will be discussing surgical management of melanoma. So I turn it over to you, Dr. Cutler.
You're on
Hi,
mute.
everyone. How are you? I want to thank Dr. Pavlik, Dr. Wolchuk for inviting me to talk today. It's really an honor and a privilege for me to talk to you guys. I also want to thank Dr. Pavlik and Dr. Minkus for really being good teammates. We kind of work very closely together and collaborate taking care of melanoma patients. And both Dr. Pavlik and Dr. Minkus have my cell phone number. And it's not uncommon that, they call me on my cell phone and say, I'm sending a patient down. So, it's been really great taking care of patients, and it's really wonderful to have such good teammates. So as Dr. Pavlik said, I'm a head and neck surgeon. And so most of the things that I do are basically cancer of the head and neck region. So what I tried to do in this talk, which is a little difficult in terms of I can't really show too many gross surgical pictures because I usually scare people that way. But the bottom line is I tried to make it pretty general for everyone that they can extrapolate from the head and neck to other areas of the body. So my job today is really to talk about the surgical aspects of more advanced melanoma cases. So what usually happens, Dr. Minkus would see a patient and she realizes that this tumor is bigger and deeper and needs surgical management, mostly of the lymph nodes, as well as the head and neck melanoma. So what I'm going to talk about today are some key features of melanoma. I'll talk about some principles and pearls of surgical treatment, some updates in management and some future directions. How do I go forward here?
You should have control now, so you can just click on the screen, and then you would
Okay.
want to use your arrows.
Okay.
And you can use the back arrow to go back. There you go.
Sure. Thank you so much.
No
So this
problem.
is an example. I'm going to start off with a clinical case. For some reason, it went backwards. Sorry.
So the right arrow will bring you to the next slide, and the left arrow will bring you back.
Sorry. Yeah, it's just not going. So I apologize.
Let's try that again.
Yeah, it's not going backwards.
Okay, no problem. You can just let me know when you'd like to advance to the next slide.
Can you go back?
Yes. Let me just.
Sorry about. Yeah. Now, yeah, just go forwards now.
One more?
Yeah, please.
No problem.
Yeah. So this is just an example of a patient that I would see that would be sent from Dr. Minkus's office, for example. This is a 70-year-old female who has a history of sun-damaged skin. And, if you look at her history, she's had a previous, cancers of the forehead, like a basal cell and other skin cancers, because she's been sun exposed. And she usually would be an enlarging 1.5 centimeter irregular pigmented lesion along the right temple region. Can you go to the next slide? So she undergoes a punch biopsy, which Dr. Minkus nicely described, where it's a circular knife, and that revealed a superficial spreading malignant melanoma. And the depth is a little deeper than Dr. Minkus would usually kind of treat, would be 1.2 millimeters, but there was no ulceration. This patient also has scans which reveal that there's no uptake in any other areas in the body, which means it doesn't seem to be any spread. So she's staged as a little bit of a higher stage tumor of a T2A and 0M0. Next slide, please. So what do you do with this patient? Obviously, as Dr. Minkus nicely explained, she would need a wide local excision of the temple region. And that usually means that we want to basically remove the entire tumor with a rim of normal skin around it. And then we do reconstruction, whether it's doing local movement of skin, or in this situation, I would usually use a full thickness skin graft, which we take from the lower neck. But the big issue here with this patient is that because the melanoma is 1.2 millimeters in depth, which means that it's a little bit deeper, it gains access to the lymphatic system, and it could spread to the lymph nodes in both the parotid and the upper neck. So we have to do something to kind of evaluate those lymph nodes. What we found is that sentinel lymph node biopsy can work very well in doing this. What we do is we inject some radiotracer dye around the tumor, and that gets taken up by the lymphatics, which then allows us to identify the first lymph nodes that drain that area. If the sentinel lymph nodes are negative, then we feel really good that there's really no evidence of any spread, and we can observe this patient, and I will send to Dr. Pavlik for a medical consultation. If the sentinel nodes are positive, for example, then we have to really think about removing all the lymph nodes in the area that drain that melanoma. And then obviously sometimes we have to think about postoperative radiation. Go to the next slide, please. So, the biology, which I just want to go over briefly, melanoma is an unusual type of skin cancer where it's really derived from what we call the neural crest cells. And it can be what's called a great masquerader. One of the problems that I have surgically when I'm doing margins on a melanoma is you can't identify it on what's called frozen section. What frozen section is we send little pieces from around the margin of our dissection, and in most other cancers, we can see the cancer on the microscope. But melanoma, it's very difficult to do that because you need to stain it with certain stains, which I've listed here. And so the bottom line is we really can't do these frozen section margins. Obviously, as Dr. Minkus said, it's really caused by DNA damage and UV light, and it is important to protect yourself from the sun. The one thing that's important to me is, a lot of these melanomas either grow kind of horizontally, which you can see in this over here, or vertically. And the bottom line is vertically is always worse than horizontal, because obviously the problem for me is that as it gets deeper, it gains access to the lymphatics, access to the bloodstream, and it can spread. Next slide. Melanoma is interesting biologically and from a genomic standpoint. It has different mutations, which I'm not going to go over. One of the interesting ones is a BRAF mutation, which is also found in thyroid cancer. But the bottom line is from this slide is that melanoma has high tumor mutational burden, which means that there are a lot of mutations associated with this tumor. Next slide. There are different subtypes that Dr. Minkus also explained. There's superficial spreading, which is more of a kind of a horizontal growth pattern. There's nodular, which more has a vertical growth pattern, which is obviously more concerning. There's the lentigo maligna and the acrolitiginous. There are other subtypes that I deal with. One of the ones that is difficult for me to deal with is, we talked a little bit about it in the beginning, was mucosal melanoma. There's something called desmoplastic melanoma. And then Dr. Minkus showed an example of amelanotic melanoma, which is really hard to diagnose because it doesn't look like the normal melanoma. Next slide, please. This is just an example of the ABC, and I'm not going to go into this, but I will say in terms of my kind of bias in terms of biopsies, one of the most important things, as I hope you understand, is that the depth of the melanoma or the thickness of the melanoma is the most important. So a punch biopsy, which kind of goes through the melanoma and gets to the base of the melanoma, is really what I prefer the dermatologists do. Sometimes with shave biopsies, where they just shave the top, you kind of underestimate the depth, and it's difficult for me to kind of figure out what to do surgically. And the biggest problem that I have is when someone will do what's called an excisional biopsy, where they kind of remove the entire lesion, but don't do an oncologic procedure where the margins are too small. And then I have to go back and kind of excise something that's already been excised, and it's hard to know where to go. So this is a little bit of a plug for us surgeons out there. I think the punch biopsy is always much better than the shave or the excisional biopsy. And that all has to do with depth, because I really want to figure the depth out, because I have to determine whether there's going to be, do I need to do a sentinel node? Where do I have to look for my tumor? How deep do I need to go surgically? It's also important that the surgeon, when they're examining you and examining the pathology and the history, is to do a complete physical examination, including the parotid and neck. The other thing that we have to think about is when you look at the melanoma, it's important to kind of realize that there can be satellite lesions, which are small melanomas that are kind of discontiguous or not attached to the main melanoma, which can, think about how we have to do in terms of the exact excision. Next slide, please. This is an example of the staging system, and this is like the 8th edition. And if you look at the staging system, it goes from 1 to 4, and it all depends, again, on the thickness. The thicker the tumor is, the higher stage it is. And there's also this component of ulceration. When you have a tumor with ulceration, it kind of upstages that tumor. So ulceration is always worse. Can you go to the next slide? If you see this circle here, go back one, I'm sorry. If you see here, I circled this ulceration at 8 millimeters. And this is basically where I usually get involved surgically. When you have a T1B or more, which is basically a melanoma that's more than 1 millimeter thick or less than 1 millimeter thick and has ulceration. Next slide, please. So this is the other staging system. This is the end stage, which is basically the lymph node status. It has to do with how many lymph nodes are involved, and whether it's macroscopic, in other words, gross lymph node involvement versus microscopic. And then obviously the M is, distant metastases. If you look at how the stages work, and I'm not going to go into this in detail, is once you have lymph node metastases, is usually where I get involved. Usually you're stage 3 and above. Next slide. So Dr. Minkus also went over this, but this is the excision situation. It really depends. The margin status really depends on the thickness. As you go up in tumor thickness, the margins increase. Now, one of the things to think about, and this has to do with me surgically, is that when you're in the head and neck region, and say you have a melanoma next to your eye. You know, you can't, even if you have a deep melanoma, if you think about 2 centimeter margins around something next to your eye, you're talking about removing your eye. That doesn't make any sense. So it really depends on other important structures that are next to the melanoma and how much margin can you take without causing issues for the patient. And of course, not only do we have to think about, you know, the periphery of the tumor, we also have to think about the depth. You know, are we getting enough resection of the tumor deep wise? And these are things that I'm thinking about surgically. Next slide. So, you know, the primary tumor, as we said, is treated with local excision. But again, my big thought is like, what is the probability that this melanoma that I just excised is going to spread to lymph nodes? And when it spreads to lymph nodes, that basically changes the prognosis for survival. That makes it a worse survival situation. Now, I have to be honest with you, the majority of melanomas that I see have no clinical evidence of melanoma, at least on scanning, but I'm always thinking, like, could there be microscopic disease within the lymph node that I'm missing? Now, what we used to do, and this goes back to when I was a resident, you know, we didn't have sentinel lymph node. This is 25 years ago when I was a resident. We didn't have sentinel lymph nodes, and we didn't have any immunotherapy or any good drugs to treat melanoma. It was very difficult to treat melanoma at that time, and people did poorly. But what we would do, because we had nothing else, we would do very large resections of the lymph nodes, and then we really wouldn't have any other treatment for them. And even though we did these large resections with a lot of complications, we didn't really improve their survival, which was very frustrating for me as a resident. But what's happened now, can you go to the next slide, please? Well, what now we have is that instead of doing these large resections of lymph nodes, we now understand that sentinel lymph node biopsy is just as good to evaluate the nodal status and much less invasive with much less morbidity. The hypothesis of sentinel lymph nodes is that each area of the skin drains to a specific number of lymph nodes. And those first draining lymph nodes that drain the primary site harbor the nodal metastases and could be used to determine the nodal status. So instead of doing these large resections, we can just find those first lymph nodes that drain that area of the skin, remove them, and then decide whether we're going to do any further treatment. Next slide, please. So how does a sentinel lymph node biopsy work? What we do is when you have your primary melanoma, or where your melanoma is, we then take you to nuclear medicine and we inject a radiotracing dye or a localizing agent. The one that we use here at Cornell is called technetium. It's a radioactive dye that accumulates in the fluid in the skin and then drains in the lymphatics into the nodes, and it gets stuck in the lymph node. It accumulates in those lymph nodes, and then we can trace those lymph nodes with a gamma probe, which is a radioactive kind of Geiger counter. If you look here in this picture to the right, it looks like almost like a shadow. You can see that we injected around this person who has an arm melanoma, and those radioactive tracer then gets taken up by you can see in the lymph node in the armpit. Well, then what happens is we take you to surgery, we find these sentinel nodes and take them out and send them to pathology. We sometimes can use other tracer dyes. For example, we can use what's called vital blue or methylene blue, where we inject not only the radioactivity, but we inject a blue dye. So if you see this picture to the right, you can see there's a radioactive blue lymph node. We take that out and send it to pathology. Next slide, please. So basically, you know, how do we manage people who come to my office with what we think is N0 neck, which means no lymph nodes, but a primary melanoma? And so if you look at this study that was done, and this is called the MSLT1 study, and this is highly quoted in the kind of melanoma surgery literature, is that, you know, it looked at kind of whether sentinel lymph node was better for the patient. And the indication for the sentinel lymph node was, as I said, melanomas over 1 millimeter with ulceration or other prognostic signs. For example, if it was ulcerated, if there was regression, young age, high mitotic rate, this is the patients who got the sentinel lymph node. Next slide. So here's the study. And this is basically they took about 1,300 patients and they randomized them into patients who had a melanoma. We either observed the nodes in about half or did a sentinel biopsy in the other half. Next slide, please. Go ahead. And what we found is that when we did the sentinel nodes, about 16% of the patients had positive lymph nodes or positive sentinel nodes. But we had an issue with some patients, even though we took the lymph node out and it was negative in pathology, they ended up recurring in the lymph nodes. So there's a false negative rate of about 4%. Next slide, please. So if you look at the survival, and these are survival curves looking at melanoma-specific survival, when you did the sentinel biopsy or you observed, there was no difference in survival, as you can see on the left side. However, if you had a sentinel lymph node negative biopsy, in other words, was not positive, you did much better than if you have a sentinel lymph node positive. So a negative did much better than a positive. So sentinel lymph node is definitely prognostic, and that's why we use it today. Next slide, please. And the other issue is that when you did the sentinel node and found the lymph node that was positive, and you compare it to patients who were observed and then developed recurrence in the neck, the patients who had the sentinel node did better. And you can see that here. So identifying the positive nodes earlier improved the survival in patients with melanoma. Next slide. And this is an example for both intermediate thickness, which is between 1.5 and 4 millimeters, and thick melanomas more than 4 millimeters. So it is effective, and there is some survival advantage to undergoing sentinel lymph node biopsies for microscopic disease. Next slide, please. So sentinel lymph node is prognostic. The sentinel lymph node biopsy did not improve survival compared to the observation arm, but the sentinel lymph node biopsy positives did better from survival than patients who were just observed and then developed recurrence. And there was a false negative rate of about 4%. So the question is, when you have a sentinel lymph node biopsy, what do you do next if it's positive? Do you then go ahead and remove all the lymph nodes? Is this thing called a completion neck dissection helpful? Next slide. So then they did this next study, which was the MSLT2 study, where they compared patients who had sentinel lymph node biopsy positive, and they randomized them into doing a completion lymph node dissection, which means removing all the lymph nodes that drained from that area, versus people who were observed. And they basically compared these two from a survival standpoint. Next slide, please. And this is an example. You can see here the red and the blue line comparing observation versus doing a completion dissection for survival. You can see there was no difference between them in terms of how they did. Next slide. However, if you look on this kind of curve on the left, when you did the dissection, then you basically prevented recurrence in the neck. So your recurrence-free survival was better compared to the overall survival, which was no better. And the reason for that, if you look at the curve on the right, was that the distant disease was the same. So it still spread distantly. Next slide, please. So really what my thought is that does a completion nodal dissection, even if does not improve your survival, it does improve regional control. So there are a lot of people who have a lot of thoughts about it. This is a little controversial about whether you remove the lymph nodes or not. Now, in these studies, head and neck was kind of underrepresented, and regional control in the head and neck region is very important. And it is especially important in the head and neck. And obviously, these neck dissections or completion neck dissections are much less morbid and have less complications than other nodal basins. But the argument against completion dissection was, these dissections can be quite extensive and there is some morbidity. So what do you tell the patient? Next slide. What's been happening now is that this completion neck dissection is being less important because we now have better drugs to treat these. So even if you have neck positivity, these patients do much, much better now with the advent of immunotherapy, which I've listed some of the drugs that are approved for melanoma. And obviously, Dr. Pavlik will discuss this in detail more. Next slide. Obviously, these immunotherapy for stage 3 melanoma, which is basically patients who have positive lymph nodes, when you got immunotherapy, they did better than if you did not get immunotherapy, which you can see here on this graph. Next slide. And even when you had a resected tumor that did not have lymph nodes and you got immunotherapy, you definitely did better with the immunotherapy than not. Next slide. So the summary is that there even is now less justification to do a complete neck dissection because of the advent of immunotherapy. People are doing better by just going on immunotherapy and not having these big resections that we used to do. And the prognostic value of sentinel lymph node biopsy is important that way, because then we know that we need to give them some other treatment like immunotherapy. Next slide. In terms of when you have a positive lymph node or a grossly on sentinel biopsy or a grossly positive lymph node at presentation, how do we treat it? And just so you understand, neck dissection, when I've been talking about neck dissection, basically means we remove all the lymph nodes in various draining basins in the head and neck. And this is just an example. Go to the next slide. When you have this line here, which basically divides the head into anterior and posterior, really allows us to think about the drainage patterns. If your primary melanoma is in front of this red line, then you have to basically remove all the lymph nodes in the parotid gland plus the lymph nodes in the anterior neck, where if you have a melanoma behind this red line, then you have to remove the lymph nodes behind the scalp and then into the posterior neck. Next slide, please. And then what's been happening lately, and this is basically thanks to Dr. Pavlik and Dr. Wolchek and kind of understanding how immunotherapy works, is a lot of my patients now are getting immunotherapy first to basically shrink the tumor or make the tumor go away. And then I do the resection and the lymph node dissection, and then they get immunotherapy afterwards. So this kind of neoadjuvant or pre-surgical immunotherapy, surgery, and then immunotherapy afterwards. And if you look at this kind of schema, how they do much better than just getting immunotherapy afterwards. And I'm sure Dr. Pavlik and Dr. Wolchek will talk about this in more detail. Next slide, please. And if you look at NCCN guidelines, they're now considering doing these neoadjuvant therapy, especially in the context of a clinical trial for patients with N-positive or positive lymph nodes at presentation. Next slide. So basically, just some concluding remarks and some principles. The most important thing for a surgeon in terms of melanoma is the depth. And based on that depth, what is the risk of developing lymph node metastases? And then what do you do about those lymph node metastases? So the role of sentinel lymph node biopsy is probably the most important advance in the management of these patients. And I would say that the advances in systemic therapy has really significantly impacted survival and treatment decisions, even for surgery, compared to when these immunotherapies didn't exist. And I think the neoadjuvant treatment for locally advanced disease, and Dr. Pavlik and I have treated many of these patients, they just do so much better than compared to other patients in the past. Now, there's a lot of things that I didn't discuss. I mean, obviously, I only had a half hour, but the bottom line is there are a lot of technical nuances about surgery. I did not show you a lot of scary pictures of surgery, but the bottom line is there are a lot of technical things that has to be discussed with the patient when you're talking about the surgery. We also didn't talk about in-transit metastases, which is definitely a more complex topic, desmoplastic melanoma, as well as mucosal melanoma. Next slide. So I want to thank you all for listening, and I hope you learned a little bit, and I'll answer any questions if there isn't.
We did get one question while you were speaking, and I'll give everyone a moment if they have any other questions. I know that patient advocacy for a lot of people has kind of really exploded in the last couple of years. Should a patient take it upon themselves to schedule an appointment with you for a second opinion? Or is that something that they should wait for their dermatologist to refer you to?
Yeah, that's a very good question. I think, I mean, obviously, I'm always happy to see people that they come to me, but you want to be you want to need me. You know what I mean? You don't want to see me for no reason. And so if you have like a small melanoma that is not very thick, then you don't need really a head and neck surgeon or a surgical oncologist. You know, a dermatologist can take care of that. However, if you start getting into more thicker, deeper melanomas, then, you know, that's something that you really need to see a surgeon for. And, you know, obviously a second opinion is always a good idea.
Perfect. Thank you so much, Dr. Cutler. And I will turn things back over to Dr. Pavlik.
All right. Well, again, I really want to extend my thanks to Dr. Cutler for spending some time with us this morning and giving us a wonderful overview of the surgical management of melanoma. And yes, it's truly been a wonderful partnership that we have in treating patients together. So it makes life so much nicer when everybody's on the same page. And working with Dr. Minkus, I think it's a great relationship that we have, and we all really do work together as a group. And so without any further delay, I will now turn this over to Dr. Jed Wolchuk, who will talk about the different therapies for melanoma. Dr. Wolchuk.
Thanks, Dr. Pavlik, and thanks again to the MRF for bringing us all together today. And I also want to thank Doctors Minkus and Cutler for making my job a lot easier by giving a lot of the important background. So I'm going to be talking, and I'm not sure, Lisa, I can't seem to control the slides, unfortunately. Okay, that's great. Thank you so much. As was alluded to by Dr. Cutler, there are various approaches to treatment of melanoma in its more advanced presentations. Basically, we're talking about melanomas that have burrowed a bit deeper into the skin, have involved the lymph nodes, or in rarer circumstances, have spread to distant sites in the body, process we call metastasis. And so on the left side of the slide are the ways that we treat the tumor, the melanoma. Surgery, which was just very nicely outlined. We don't use chemotherapy very much for melanoma anymore. We can use radiation therapy, which you've heard about, which you will hear about from Dr. Beal. And we can also use targeted pathway inhibition, so inhibitors of things like BRAF and MEK, which Dr. Cutler also alluded to. These share one thing in common. They treat the tumor directly, either by excising it, giving it medicines that stop the melanoma cells from dividing, and that's chemotherapy or radiation, or giving a treatment modality that also stops the melanoma cells from dividing, which is radiation therapy. Now, on the other side of the slide is immunotherapy, and that works in a more indirect way by enabling the normal person's immune system to recognize the melanoma and to control it better. And that has been a major step forward, along with targeted pathway inhibition, in our ability to treat melanoma. Okay. Next slide, please. Okay, so when I first started practicing in the year 2000, there were a total of 2 approved therapies for metastatic melanoma. One was a chemotherapy called dacarbazine, or DTIC, which helps maybe 10% of people for relatively short periods of time. And there was a medicine, an immunotherapy called high-dose interleukin-2, which is an immune hormone that, when given at quite high doses, can, in a relatively small number of people, cause cure of even widely metastatic melanoma. The problem with interleukin-2 was the low response rate, less than 15%, the even lower durable complete response rate, which is probably about 3 or 5%, and the challenge of giving it, it needed to be administered in an inpatient setting, often in a step-down unit or an ICU-like setting, because of some of the temporary side effects that accompany its use. But I would say that what interleukin-2 taught us was that when the immune system is properly tuned, it can control melanoma in a very impactful way. Okay, next slide. So fast forward to 2023, and this is the list of approved therapies for melanoma. And you can see that the list has grown quite a bit. Many of these, the ones in red, are immunotherapies. The ones in black are either chemotherapy or targeted therapy. And so we're very, very pleased with the progress that's happened because it provides hope for people who are facing a new diagnosis of melanoma. Next slide. You've heard a little bit about the BRAF mutation. This is a mutation that develops with the melanoma. In people with melanoma, it is not something that they're born with. And basically, RAF or BRAF is essentially a switch that controls the melanoma cell's ability to divide. And when it gets altered through a mutation, it basically puts that switch in the on position permanently. And so it leads to the kind of ceaseless proliferation that melanoma cells can demonstrate. And in probably the late 90s, early 2000s, there was a lot of activity to develop BRAF inhibitors, and several of these have been approved. They're usually given along with inhibitors of another protein that you can see on the right side of the slide called MEK. Together, these medicines work better, as I'll show you in the next slide. Okay, and this is a kind of amalgamation of data from Dr. Ryan Sullivan from the Massachusetts General Hospital, who just presented a summary at the recent ESMO Congress. And you can see a series of clinical trials showing combinations of BRAF and MEK inhibitors being better than BRAF inhibitors alone. And on the bottom graph, what you can see is an important study that was done through the NCI cooperative group called the ECOG Akron group, which asked the question, what is the best first treatment for metastatic melanoma? Is it immunotherapy or is it targeted therapy? And what you can see in that survival curve with the black line on top is the combination of nivolumab and ipilimumab, two immunotherapies, given first, with crossover if people should have growth of disease to the targeted therapy, or in the red curve, dabrafenib and trametinib, which are targeted therapies, given first. And what is very evident is that it is advantageous to start with the immunotherapy and not with the targeted therapy. Now, this is not an absolute rule, because there are some people who have autoimmune diseases or other concerns with the use of immunotherapy that might make us want to use targeted therapy first. But in general, without any complicating factors, we would ordinarily reach to immunotherapy first. Next slide. So what is immunotherapy and why do we use it? So our immune systems are essentially designed to distinguish things that look like self, or normal body parts, from things that don't look like self. And in general, things that don't look like self are bacteria or viruses. And so we're all very aware that the immune system is quite good at recognizing foreign infectious pathogens. COVID-19, for example. But the question is, does cancer look like, let's just tone down, does melanoma look like the normal melanocyte that it came from, or does it look like something remarkably different? Now, thankfully, in the case of many melanomas, it looks remarkably different. And that's good, because what it means is that the immune system is going to be more likely to see it as being something unlike self and make a baseline immune response to it. Now, why does melanoma attract the interest of the immune system? We believe that it is because, at least in part, of the accumulation of genetic damage associated with sun exposure. And what that leads to is damage to DNA. And when DNA is damaged, then the resulting proteins that the DNA has instructions for building lead to abnormal appearing proteins. And the immune system sees this as being something unlike self, and it jumps into action. Next slide. But getting the immune response started is a multi-step process. There needs to be a very specific interaction of, does it look like self or not? And that's like inserting your ignition key into the car. And I'm showing my age by not having a key fob there, but we'll go with it for now. There needs to be an accelerator pedal to get the immune system started, and immunologists call that accelerator pedal CD28. Then there are a series of brakes. One of those brakes is called CTLA4, which was the first of what are now known as immune checkpoint molecules. Another molecule in this family is PD-1. And then there are ways to steer the car once it's been accelerated, and if the brakes are disabled with one of the immune checkpoint blocking antibodies like ipilimumab, nivolumab, pembrolizumab, relatlimab, atezolizumab, all of these whatever mabs, as I call them. And then once the immune system is hyperactivated, maybe we can steer it toward a target of interest with a vaccine. Next slide. So right now, the most powerful therapy that we have uses a combination of ipilimumab to block the brake CTLA4 and nivolumab to block the brake PD-1. These are two molecules, CTLA4 and PD-1, that are normal molecules that keep our immune system from getting hyperactivated. And when we temporarily block them with these whatever mabs, these T cells or immune cells become supercharged, and they can overcome the immune suppressing influence of the melanoma. Next slide. What does this result in? Well, in the first clinical trial, the phase 1 clinical trial of the combination of ipilimumab and nivolumab, which we performed at when I was at Memorial Sloan Kettering, along with colleagues at Yale, Doctors Kluger and Snoll, we saw that when we used a combination of these two medicines together, more than half of people had rapid regressions of their metastatic melanoma tumors that seemed to be durable. So on the left side of the slide is something called a spider plot. Each of those lines is a graph of the amount of melanoma tumors that an individual person has. Each line is a different person, and if the lines are going down, it means that the tumors are getting smaller. One representative patient is on the right side of the slide. This is a patient of Dr. Kluger from Yale. These are CAT scan images. The orange arrows on top point to melanoma tumors, and you can see that after 12 weeks of treatment, almost all of those orange arrow indicated tumors have gone away. So this is a very impactful treatment. Next slide. However, we at the time were unsure whether the combination of treatment was better than the individual component parts. So we designed and led a large clinical trial that looked at the combination of ipilimumab alone, nivolumab alone, or the combination in people with newly diagnosed melanoma. This is a study that if you do any kind of internet searches on melanoma treatment, is called Checkmate 67. It's one of the largest studies done in metastatic melanoma, and we have very long-term follow-up, now around 7 years from this trial. Next slide. What we know, if you look at the best overall response rate, the number of people who have significant shrinking of the tumors on scans, is that the combination treatment of Nivo plus Ipi leads to nearly 60%, 58% of people having significant shrinking of the melanoma. When we give nivolumab to block PD-1 alone, it's almost as good, 45%. And if you give ipilimumab alone, something that we don't do very much anymore, just 19% of people have a shrinking of the melanoma. Importantly, at the bottom of this table, the median duration of response has not been reached with 6.5 years of follow-up for both of the nivolumab containing arms. So this gives us a lot of confidence that the responses that we see last many years. Next slide. And what this has really led to is a fundamental change in the way that we think about metastatic melanoma. So on the left side of the slide was a clinical trial that was completed in 2000 by Professor Mark Middleton from Oxford in the UK, which compared two different chemotherapy drugs, dacarbazine or its oral equivalent, temozolomide. And you can see that with the chemotherapies, 20% of people or less were alive for 2 years or longer. When we look at the most recent data from Checkmate 67, if you look at the top line, the orange line, which is nivolumab plus ipilimumab, nearly 50% of people are alive for 6.5 years or longer. So we've gone from a median survival of 6.5 months to a median survival of just over 6 years in a relatively modest period of time. We definitely still have work to do, and that is why organizations like the Melanoma Research Foundation are so important. But we believe that this is a time of great hope and a time for really, recognition that we've come a long way in terms of controlling a disease that was in the past nearly uniformly fatal. Next slide. So I should also mention before we go on that there are also side effects that come from immunotherapy, which include pretty much any itis that you can think of, inflammation of almost every body part. And that is certainly more common with the two medicines rather than with one medicine alone. And sometimes that leads us to choose one medicine versus two, depending upon the individual presentation. Thankfully, we've learned how to manage these side effects. Few of them are lifelong, and most are controllable with just a few weeks of medicines like prednisone to temporarily calm down this overactive immune system. Now, I want to go through a little bit of the data that Dr. Cutler referred to in terms of adjuvant and neoadjuvant therapy. It's just a definition that adjuvant therapy is, in this case, immunotherapy that is given after surgery to remove the melanoma, either from a deep primary in the skin or melanoma that has found its way into lymph nodes. And neoadjuvant therapy is giving that same immunotherapy for a couple of weeks before surgery. And so very recently, our colleagues from the Southwest Oncology Group, led by Dr. Sapna Patel from MD Anderson Cancer Center, asked a very important question. Is it more advantageous to give this immunotherapy before or after the surgery? And one hypothesis is that the response to this PD-1 blocking therapy requires the presence of pre-existing anti-tumor T cells that are in contact with the cancer cells. Next slide. And if you do surgery first, followed by anti-PD-1, we know that the anti-PD-1 can enhance progression-free survival. Next slide. We also know, in contrast, the administration of anti-PD-1 before surgery induces an immune response from a larger population of T cells because the tumor, which is where most of the anti-tumor T cells are located at the time, is still in the person's body and not in the pathology lab. Next slide. And inhibiting the PD-1 checkpoint before surgery induces a systemic immune response at local and different sites. Okay, next slide. But before resection of the tumor bed, leaving behind larger numbers of anti-tumor T cells. So this is the hypothesis for why giving the immunotherapy before surgery may be better. Next slide. The T cells can then be activated and circulate throughout the body to recognize and attack any melanoma cells that might not even be visible by scans. Next slide. So this was the study schema. Dr. Cutler went through this with you, so we can go to the next slide. And the results were really clear. when you give people a few doses of immunotherapy before surgery, those patients do better in terms of lack of recurrence of the melanoma at, in this case, a 2-year time point, compared to doing the surgery first and then giving the immunotherapy after. And importantly, the way that this very well-designed clinical trial was conducted is that everybody received the same number of doses of immunotherapy, regardless of which group they were assigned to. Next slide. So we now believe that neoadjuvant therapy is an important addition to the way that we think about treating people with melanoma. Another area of interest is other immunotherapy combinations. And just in the last year or two, we've had a new addition to the portfolio of treatment options, and that is a combination of nivolumab, the PD-1 blocking drug, with another drug called relatlimab. And this drug, relatlimab, blocks another immune checkpoint called LAG-3. This combination was based upon very convincing science done at Johns Hopkins, as well as St. Jude's, that pointed toward this combination as being the way to go. And some of the most important data from this trial, which was called Relativity 47, shown in the next slide, demonstrates that when you compare nivolumab alone with the combination of nivolumab plus relatlimab, you have an improvement in what's called progression-free survival. This doesn't measure how long someone lives, but rather measures how long someone lives without having a melanoma recurrence or death from melanoma. So there was a statistically significant improvement with the combination of nivolumab and relatlimab that led to the approval of this combination for the treatment of advanced melanoma. Importantly, this combination, nivolumab and relatlimab, has a much better toxicity profile in terms of the frequency of all those itises, colitis, dermatitis, thyroiditis, hepatitis, compared with the combination of nivolumab plus ipilimumab. So this is another option that we have when we're weighing risk and benefit with people and their families to select a treatment option. Next slide. Okay, I have come to the end of what I wanted to present, and I would be happy to answer any questions that have come in during this time.
So we do have a question here. It says, it looks like Checkmate 067 continues the success 7.5 years later for stage. This is great news for stage 4 patients. Is there any research or information available for stage 4 patients dealing with IMARS or side effects post 5-year treatment?
This is a really important question because we recognize that that the side effects that we create by enhancing the immune system may present very acutely during the time of treatment, but we, as of yet, do not know what the long-term ramifications are. I have not become aware of any emerging late toxicities from this type of treatment. However, this is a question that many of us in the field are very interested in, and we're hoping to develop registries for people treated with immunotherapy that look at, chronic illnesses. Like, we don't know this for a fact, but do people develop heart disease, right, more often? Do people develop dementia more often? We don't know this, but this is an extremely important question, and it's one that we have to pay attention to as people are living such a long time after immunotherapy. So thank you so much to whomever asked that.
Perfect. And then we have another question here that says the Nivo plus Rela chart only compared to Nivo, but are you able to see the questions, Dr. Wolchuk, in the Q&A?
Let me see.
I don't want to read it incorrectly because I'm not exactly sure, but I think you'll know what they're referring to.
me just see if I can get my screen up here.
At the bottom.
Yeah, maybe if you take back control, it will let me see the bot. Oh, no.
Okay, everyone. Thank you so much. We hope everyone enjoyed our brief break. And I will turn things back over to Dr. Pavlik.
Okie dokie. Well, thank you everyone for coming back. We're in the home stretch. So we're going to start the second part of our seminar with Dr. Catherine Beal, who is the Director for Brain Metastases and Survivorship at Weill Cornell. She is a radiation oncologist. And without further delay, I give you Dr. Beal. Thank you for joining us.
Good morning. Can you hear me?
Yes.
Okay, great. Well, thank you so much for inviting me, Dr. Pavlik and Dr. Wolchuk. And I've been very inspired by all the different talks this morning. And my career is treating all types of brain tumors with radiation. And one of my most special interests is radiation for melanoma brain metastases. Okay, for some reason I can't advance my slides either. There, thank you so much. So just to put it in perspective, there are approximately 200,000 patients per year in the United States who are diagnosed with brain metastases. And many more patients, roughly double that, walking around with brain metastases. And that's because we now have many excellent treatments for patients with all types of cancers. And so even if a cancer spreads into the brain, patients are living a much longer period of time. And we're actually even able to cure some of those patients. So I would say in my career, the single most inspiring change in the past decade is that we can now actually cure a number of patients with brain metastases, and in particular melanoma patients. So I'll speak to you a little bit more about why that is and how this works. So first of all, the incidence of brain metastases is rising. And that's in general due to better screening. So we have protocols if patients are at high risk for developing brain metastases. Some patients we screen with MRIs to look for those brain metastases. And then also with better imaging, we're able to detect smaller brain metastases, so find them at an earlier stage. We also have, as you've heard from Dr. Wolchuk, much better systemic treatments. So systemic treatments mean treatments that go everywhere in your body, like checkpoint inhibitors or targeted therapies or just general chemotherapy. And these better systemic treatments lead to prolonged survival in patients who have advanced or metastatic disease. And as patients live longer with more advanced disease, they then have more time to develop brain metastases. So with these better treatments and earlier diagnoses, patients are also at this point in time more likely to be found with only a few brain metastases rather than many, many brain metastases, as we used to see more commonly when patients would present with much more bulky and advanced disease. And due to the improvement in both technology from our end, and then the prognosis of patients due to better treatments, we now use high-dose radiation that's very accurate, called stereotactic radiosurgery, much more frequently. And this approach is used almost exclusively now for brain metastases in patients with earlier disease versus something called whole brain radiation, which, as the name implies, treats the entire brain with radiation and can cause a lot of side effects and also is actually not as effective lesion per lesion. So the high-dose focused radiation to each tumor leads to better prolonged control per spot that you treat. And if you are using just spot treatment, patients actually will follow up. We'll see them in follow-up with repeat MRIs. And about half of those patients overall will eventually develop another brain metastasis or 2 or 3, requiring more courses of stereotactic radiosurgery. Next slide, please. So just to put our topic today, melanoma, into perspective, this slide demonstrates what brain metastases epidemiology landscape is in the United States. So the first line up here, the first row, shows you the relative number of brain metastases we see. So in my clinic, I see lots of patients with brain metastases, and about half of them have lung cancer. So lung cancer, primary disease, goes to the brain. So if I see 100 patients with brain metastases, about 50 of them will have lung cancer as their initial source of disease. About 15% will have breast cancer as their initial source of disease. And interestingly, about almost 10% of patients have melanoma as their primary source of disease, even though metastatic or advanced melanoma is not nearly as common as it is in patients compared to lung cancer and breast cancer. And another way to look at this is that if you have advanced melanoma, you have about a 7% chance of developing brain metastases. So the likelihood of melanoma going to brain is actually relatively high, higher than breast cancer, certainly higher than colorectal or gastrointestinal cancer, and really only second to lung cancer. Next slide. So how and why do brain metastases develop? The process may be a bit different from breast cancer, lung cancer, other types of cancer to brain. But in general, the process is that there's a primary tumor site. So a tumor that perhaps a skin tumor on your face or some other place in your body, or even a non-skin melanoma primary tumor. And that tumor, as we've heard, can go to local lymph nodes. It can also just spread locally and invade into the blood vessels in that area, wherever it's arising. And some of those cells can break off, get into the vasculature, get into the blood vessels, and travel through circulation in the body, and then reach the brain. There's a concept of something called the blood-brain barrier, which prevents toxins from getting into your brain. Toxins, so like if you get food poisoning or some sort of virus or bacteria, this concept of the blood-brain barrier is a protective mechanism that prevents some of those toxins and foreign substances from getting into the brain. And likewise, the blood-brain barrier is an important concept because it prevents most chemotherapies and most any sort of systemic type of therapy, even immunotherapy itself, from getting into the brain. But if cancer cells spread into the brain through the blood vessels, some of them can destroy sections of that blood-brain barrier and make their way into the brain, plant themselves into the brain, invade, and then proliferate there. And that's what forms a tumor or a brain metastasis. And there are lots of questions with this. So on the right, you'll see a panel of questions. And these are things that we don't always understand. We think we have some concepts, but it's probably different cancer per cancer and patient per patient. But one of the questions is, do brain metastases happen early when a patient is first developing their cancer, or does it happen, do they pop up later in disease? We will see some patients who present with metastatic disease of any type of cancer, but let's just say melanoma. So they might have a melanoma, advanced melanoma, and at diagnosis, it's seen perhaps in the lungs, and nothing in the brain. And then eventually, perhaps a year later, or even a couple of years later, they may be found to have a brain metastasis. And those patients, it's suggested, might have small disease in their brain that's not addressed by the systemic treatment they're on. And over time, those tumors slowly grow and become eventually large enough to be detected and require treatment. Likewise, sometimes patients develop brain metastases maybe later in disease development if the cancer is becoming more aggressive or changes somehow and has a later biologic event allowing it to spread into the brain. Next slide, please. So once we define or find a brain metastasis, as you can see on the right picture that's circled in red, we generally treat these tumors with something called stereotactic radiosurgery, which is high dose, very focused radiation just to that target. And on the left, you can see a display of many different beamlets of radiation that are all converging together on this one target. So in essence, it's an array of innumerable little beams that all come together and converge to deliver high dose radiation just to that little target. Next slide, please. And within the stereotactic radiosurgery world, there are many different technologies to deliver the same treatment. And a lot of patients will ask me, what's better, Gamma knife, Cyber knife, Zap, TrueBeam? And what I generally explain to patients is that although the technology is somewhat different, the ultimate effect is the same. And it's sort of akin to driving an Audi versus a Mercedes versus a BMW from point A to point B. Technology is slightly different, but the engineering is excellent for all of them. And you will get from point A to point B in essentially the same amount of time. So, but just to explain what these different approaches are, the TrueBeam is a linear accelerator, and that's the top picture there. And this is what we use for the vast majority of our radiation treatments. A linear accelerator produces photons for treatment. Photons are delivered by or created by accelerating a small particle called an electron down a magnetic field. And at the end of this magnetic field, it hits a target and the energy is released as a photon. A photon is an X-ray, just like X-rays that you have when you go get a chest X-ray or some sort of diagnostic X-ray. The X-rays or photons that we use for treatment are a higher energy form of an X-ray than diagnostic X-rays. And that high energy X-ray has the capability of damaging the DNA of the cancer cell or damaging something called free radicals. And those are split apart and also can cause damage to the cancer cell. There's also a machine that is called a gamma knife that has cobalt radioactive sources. So instead of having a linear accelerator, it has 201 little tiny sources of cobalt all distributed in the head of the machine so that when a patient, this is the second picture, so that when a patient is on the treatment table and slides into the machine, these cobalt sources are in an array shielded behind thick lead. And those 201 sources can be used in different configurations to very precisely and accurately with high conformality treat the target or many targets that are in the brain. And likewise, the cobalt releases photons, which are also very high energy photon and have the same biologic effect as the photons that are produced from a linear accelerator. More recently, there's been a new engineering feat to produce a machine called the Zap, which is also a linear accelerator. And this has a slightly lower energy, but same biologic effect for the tumor. And that's the bottom picture there. And this unit is similar in terms of the precise and accurate ability to treat tumors. But instead of having to have a giant shielded room, which we have to have for our most of our linear accelerators, this one has the shielding around it, which is that unit you see in silver surrounding the patient. So this unit actually is a little less expensive and more flexible for setting up in different areas. And it's actually, there's been a lot of international interest in acquiring these units and placing them in even remote places because you don't need the same sort of huge system to support them. So I just wanted to point out that all the stereotactic surgery systems come with image guidance. They all have, so meaning before treatment, we image patients on the treatment table to make sure they're set up precisely. They all come with motion monitoring systems so that during treatment, we're watching patients closely and can detect if they move at all within sub-millimeter accuracy. And if they move more than a millimeter during treatment, the machine is stopped automatically, we realign them and then resume treatment. The patients are also, in general, most of them are now, we use mask systems, which you see in the upper right-hand corner there, the patient's in a comfortable mask during treatment, which is removable, not fixed. And this makes our treatments also much more flexible. In the past, we used to use something called fixed frames, which were actually affixed to the patient's skulls with little screws that were actually, or pins that were actually screwed and affixed to the skull for each treatment. So those were much less comfortable, actually quite uncomfortable, and not as flexible for the way we like to treat now. There are some differences with all these different units in terms of planning efficiencies and some differences in terms of treatment efficiencies. But from a patient perspective, the experience is relatively similar between all of these units now. And absolutely, the treatment effectiveness, so the lesion per lesion treatment effectiveness is equivalent between all of these different systems. And I think that's the most important message to understand from this slide. Next slide, please. So this is just a demonstration of what we are capable of on our linear accelerator-based systems. This is just an example I wanted to show you. So this patient, you can see on the bottom right-hand picture, has 4 metastases you can see in this particular slice of their brain. And with our linear accelerator treatment planning systems now, we have the capability of treating all 4 of these spots simultaneously. And for patients who have many, many brain metastases, let's say they're presenting with 10 or even 20 brain metastases, with the linear accelerator-based approach called VMAT planning, we actually are able to treat not only all of these spots very accurately, but also very, very efficiently. And so this has made an enormous practice shift. If in the past we saw or met patients who upfront had 10 to 20 brain metastases, we would often treat with something called whole brain radiation, which was not as effective and caused a lot more side effects and much slower treatment, just because it was so hard to technically treat all of these lesions. And now with this new capability of treating many metastases with stereotactic radiosurgery, there's been a big sort of shift to using stereotactic radiosurgery, and the use rate is really rising tremendously. Next slide, please. So with that shift in our care or our practice, there have been many questions. You know, what is the right number to treat with stereotactic radiosurgery? And this is another question I get all the time from other doctors and sometimes patients. This study actually shows that patients, this is actually a study where lots of patients from several different hospitals, the results were put together, and all these patients had brain metastases of different types. Some had 1 brain metastases, some patients had 2 to 4 brain metastases, some patients had 5 to 15 brain metastases. And in the first column, you can see the total number of patients. There were 2,000 patients roughly, and about half of those, 998 in the second column, had only 1 brain metastases. Another 882 had 2 to 4 brain metastases, and about 212 patients had 5 to 15 brain metastases. And interestingly, you can see in something called distant brain failure, so that's that first row coming across, the first in the year 1, so 1 year after treatment, these patients were all treated with stereotactic radiosurgery. Interestingly, if you had only 1 brain metastases, there's about a 30% chance of you developing more brain metastases. If you had 2 to 4, about a 40% chance. And if you had 5 to 15 brain metastases treated up front, you actually only had about a 50% chance of developing more brain metastases. And this is very important because you would imagine if you had 5 to 15, let's say you had 10 or 12 brain metastases, you're probably going to have many more brain metastases. But in fact, only 50% of the patients required more radiation to their brain within the first year of their following their treatment. And this really points to the amazing advances in systemic therapy that we have now. So those patients might have presented with many brain metastases, but as they were initiating their therapy for their body, perhaps that treatment kept all the disease in their body in check. And if with a good response and control of that disease in their body, those patients didn't necessarily then have a chance for the cancer to spread and seed their brain again. Next slide, please. Another way to look at this data is looking at what we call survival from date of treatment by the number of brain metastases. And interestingly, the first graph on the left at time 0, which is the moment they're treated with stereotactic radiosurgery, you can see there are 3 lines, and those represent patients with 1 brain metastases versus 2 to 4 versus 5 to 15. And the 1 brain metastasis, 2 to 4 and 5 to 15 lines are actually relatively similar. So even though we have this sort of intuition that patients with 10 or 5 to 15 brain metastases are going to have much worse survival, there's not an enormous difference. And that also is reflective not only of the control we get with the advanced systemic therapies we now have, but also reflects the fact that we can control the brain actually quite well as well with this high dose radiation. Lesion per lesion, we're very effective at treating each of those tumors in the brain. And then the chart or the graph on the right side shows what we call the cumulative incidence of distant brain failure. So for patients with 1 brain metastases, that's the dark line on the bottom there. 2 to 4 is the middle line, and then the 5 to 15 are the tiny little dots of the third line. So the patients who had only 1 brain metastasis were a little less likely to develop brain metastases than the patients with 2 to 4 and patients with 5 to 15. But again, the curves are not so divergent from each other. And in fact, the patients who had 1 brain metastases had over a 25% chance, about a 30% chance of eventually developing other brain metastases, and those with 5 to 15 had only about a 50% chance of developing other brain metastases. Next slide, please. So specifically jumping forward into melanoma, about a year ago, we presented and this is now submitted for publication, but about a year ago, we presented our experience of looking at patients who've survived at least 5 years after stereotactic radiosurgery for their melanoma brain metastasis. So this was just from a single institution. And what we did was just took a group of patients, basically essentially many of my patients from my clinic, who had survived at least 5 years after stereotactic radiosurgery for their melanoma brain metastases, and looked at what were the characteristics of these patients. And there are a few important points I'd like to make here. One is that if the patients had reached 5 years, so in that first curve at the top under results where it says 5-year OS is about 80%, the time 0 is 5 years here. So they're starting 5 years out from stereotactic radiosurgery. So if they were that far out, they then had at least an 80% chance of continuing survival for another, 5 years after that. And most of these patients were more advanced in age and were actually dying of causes unrelated to melanoma. And then likewise, well, not likewise, actually separately, as I've mentioned, if you have a melanoma or any type of brain metastasis, you are at risk of having other brain metastases. And obviously, this makes patients very nervous. But a really important finding from this study was that in melanoma patients specifically, and these are all good players who actually survived and were essentially all cured from their melanoma. And about 50% of them actually developed more brain metastases after their initial treatment with stereotactic radiosurgery. So it's a really important lesson and very interesting finding that patients who ultimately were cured of their melanoma brain metastases still had about a 50% chance of developing more brain metastases, but this did not mean their prognosis was terrible. In fact, they were still curable. And there are lots of thoughts and not more than thoughts. There are lots of studies looking at and examining something called the abscopal effect, but basically concept of the synergy between high dose radiation, what we call stereotactic radiosurgery, and immunotherapy. High dose radiation therapy, I'm sorry, I didn't include a slide of this, releases antigens from the cancer cells. And those cancer cells, as Dr. Wolchuk has pointed out, are seen as foreign. And when the high dose radiation hits these cancer cells and releases these foreign proteins into the body, whether it's in the brain or somewhere else in the body, that allows the immune system to see those foreign cells more acutely and rev up more of an immune response. And there have been several cases published showing that for patients who've been relatively stable on immune checkpoint inhibitors, if they're then given a high dose of radiation to one site, whether it's in the brain or somewhere else, that will stimulate the immune system again to start attacking everything else in the body. So there may be something conceptually along those lines as to why these patients who develop more brain metastases still do so very well. Another point I'd like to make about this slide that's very, very interesting is that a full 25% of these patients were taken to the operating room for their brain metastases after they were treated. And that was because they had very significant changes on their post-radiation MRIs that were concerning for perhaps tumor progression or maybe some sort of very robust scarring process related to the immunotherapy and the radiation. And this is an unusually high number of patients to go to the operating room. Typically, we only take about 2 or maybe 3% of patients to the operating room to remove a brain tumor after stereotactic radiosurgery. So instead of being 2%, we had 10 times that. 25% of the patients went to the operating room because of these changes we saw after radiation. And none of those patients, this is amazing, had active disease. They all had a robust sort of cystic kind of scarring immunologic response. And so now we're starting to understand if you have this sort of cystic robust response, as Dr. Wolchuk has suggested, if you have an itis, so this is a sort of an itis situation in the brain following the radiation, that actually probably portends a good response overall. So similar to checkpoint inhibitor response in the body, if you get a robust immune response with one of those itises, we're seeing the same process in the brain as well. Next slide, please. So very quickly, as I'm at the end of my time here, I'll just show a couple patient examples. This patient you can click all the way through the end of this slide, was treated with ipilimumab and then radiation in 2009. 6 months later, the tumor still looks quite intact. She then developed seizures, and the tumor looks a little bit more robust. In fact, it looks a bit like an active tumor. Click again. And she underwent surgery to remove this, and indeed it was just necrosis alone, meaning scar tissue, no active tumor. Click, and she's now NED many years later. Here's another patient with presumed necrosis. Please just click through so you can pull up all the pictures. Yeah, thank you. And 6 months after radiation and ipilimumab, you can see that the tumor looks much more angry. There's some blood in that area. There's some swelling around it. 2 years later, it's gradually contracting. A year after that, it continues to contract. Click again, please. And many years later, the patient, actually 9 years later, remains without any evidence of disease. Next slide, please. And here's a patient who is actually a patient of Dr. Wolchuk's. One of my very first patients we treated with stereotactic radiosurgery and concurrent ipilimumab. He actually had 2 sites, but this one, 2 sites in his brain that I treated, this one was remarkable. It was this tiny little tumor you can see on the left panel. 6 months after stereotactic radiosurgery and ipilimumab, he developed asymptomatic necrosis or scarring that you can see here. We just observed it. It eventually resolved on it all on its own, but a very robust response. And he's still without any evidence of disease in his body or brain more than 10 years out from stereotactic radiosurgery. Next slide, please. I also wanted to point out there are other MABs, as Dr. Wolchuk pointed out, that we use. And there are some of them that might have slightly different responses with melanoma stereotactic radiosurgery. And one thing that we notice is there's a slightly different pattern of response in the brain as well. And with pembrolizumab and stereotactic radiosurgery, we see more rapid responses than we do with IPI or IPI-NIVO, and it's not entirely clear why that is. Why do the tumors like shrink away more quickly? But this is a paper I published a number of years ago, looking at that, comparing it to ipilimumab. And long term, it probably doesn't make a huge difference, but there's definitely a slight difference in terms of response rate here. Next slide, please. And this is a patient, actually, interestingly, who also probably had an abscopal effect. So this patient on the left panel had a MRI pre-radiation. You can see a robust tumor in the bottom part of his brain with the arrow. And then underneath that first picture, there's also one spot that we didn't see that was not treated. 12 days after SRS, he had a headache, or I think hit his head somehow. So he came in and got another MRI. And the lesion we treated was a bit bigger in the cerebellum, and that's not surprising because we've irritated that area. But also there was this frontal area that was a bit bigger that was the moment we recognized it. In retrospect, we went back and saw it, but it was one we didn't treat because it was so small we did not appreciate it. And then when he came back for his routinely scheduled MRI 56 days after radiation, you can see complete resolution of the one in the bottom part of his brain, that top panel on the right. And indeed, he also had complete resolution of the one in his frontal lobe that was not treated at all. So is this an abscopal effect? Is this just the effect of the immunotherapy by itself? It's hard to determine, but there is some effect of immunotherapy by itself in the brain, and there may also be this concept of abscopal effect going on more often than we realize as well in the brain. Next page, please. Why don't we skip this? Next page, please. Actually, I'm going to skip this as well. This and this one too. And finally, I would like to point out that one of the most important aspects of taking care of our patients is this multidisciplinary approach. And we now have a tumor board that is dedicated only to melanoma, or excuse me, only to brain metastases. And a good number of those are melanoma brain metastases. And for any patients who have new brain metastases or ongoing problems with brain metastases, we will, some of them are straightforward and we don't need to discuss in tumor board, but many of them we discuss in tumor board, and we really learn from each other with the educating each other with the new approaches with targeted therapies or immunotherapies and the local therapies that we can do, and have been able to learn and create clinical protocols and really achieve the best outcomes for our patients, not just in terms of controlling each spot, but also considering what the best long-term care is for some of the complications that may come up from treatment as well. So for anyone who has a brain metastasis from any cancer, but melanoma in particular, I do believe it's very important to seek care at an academic center with a very experienced team who has resources to all of these different elements and a multidisciplinary tumor board. Next slide, please. So in conclusion, again, an interdisciplinary evaluation is an optimal way to manage brain metastasis. Research is warranted for this. Well, it's not very, well, brain metastases are very common, but relatively unstudied condition. There are biologic differences across different cancer types, requiring different strategies and targets. And I didn't get to talk about this today, but there's a lot of progress and interest in the neurobiology. So the surrounding, what we call microenvironment. So the brain, how that supports for some patients develop of brain metastases, and how potentially the interaction between the cancer cells and the brain, we can understand that more and help to create better treatments using that understanding. Thank you so much.
Thank you so much, Dr. Beal. If anyone has any questions, please feel free to submit them. And I will turn things back over to Dr. Pavlik.
So we have no questions. So that makes me the next speaker. And I really wanted to discuss clinical trials for the simple reason that many people, I'm not touching my slides, so I'm not sure why they're moving.
Okay, hold on. There you go.
Okay. Okay. All right. So again, I'm sorry for that technical difficulty. And again, I'm not touching the slides, but they just got a mind of their own today. So I'm going to talk to you a little bit about clinical research and clinical trials, because the way that we have made such tremendous progress with respect to melanoma is really because when Dr. Wolchuk and I first started doing melanoma 20 plus years ago, as he demonstrated to you, there really was no good effective therapy for melanoma. Here we are, fast forward 20 years, and now there's in a list of FDA approved effective clinical therapies for the treatment of metastatic melanoma. And why did that happen? It happened because back in 2000, patients knew, I've got a bad disease, nothing works, I need to participate in a research study. And it was through the active participation of our patients who trusted us to give them the best effective therapy in our opinion, even if that was a clinical trial with a drug that was not FDA approved. This is what moved our field forward. These are all the drugs that Dr. Wolchuk spoke about this morning. These are the trials that we gave our patients these drugs on a clinical trial. And it's through that research that we are now able to have all these effective, good therapies. So why is it important? Because clinical trials are an opportunity for patients to obtain medicines that are not yet FDA approved, but may be the next best thing to slice bread for that disease. It may improve on a current therapy by the addition of another medicine, or it may be a totally different medicine in a different category that looks to have promise. And patients will commonly say to me, well, why should I go on a clinical trial when there are so many standard options? And my answer is always, those standard options are FDA approved. They're always going to be there. Participating in a research study provides you with another treatment option. It is another opportunity to get a medicine that once that study closes, you can't have access to that medicine unless it's FDA approved, which can be several years. So this is why thinking about participating in research is very important. It may help you, it may help other patients. But as you can see, over the last 20 years, participation of patients in these clinical trials have now availed us to having over 10 drugs that are FDA approved for melanoma. Okay, and we're going to fast. Okay, so This was just a study that we did back in 2011, so about 10 years ago, 12 years ago, that really looked at why patients did better who participated in clinical trials. And the answer was because these are more opportunities and more treatment options for patients. And so this was just our study that we did when I was back at NYU that looked at patients who got standard of care therapies versus patients who participated in clinical trials. And it really did demonstrate that patients who participated in research studies, because they were afforded more cutting edge therapies and more options, really did in fact live longer. So what kind of clinical trials are out there? Well, there are treatment trials, there are prevention trials, and Dr. Cutler talked a little bit about that. For patients who have stage 2 melanoma, there are now studies looking to see, can we give these immunotherapy medicines to earlier stages of disease to prevent high-risk patients with completely removed melanoma from going on to become metastatic. There are diagnostic trials, which means that we're looking at different types of instruments to measure disease or disease responses, as well as quality of life studies, looking to see, does our therapy not only help your cancer, but what does it do to your quality of life? Does it take away your pain faster? Do you feel better faster? Or does it take away your cancer and really make you feel terrible? Because these are very important things that we need to understand. So before we talk about clinical trials in general, it's very important to understand that there are different types of trials that are called phases. So phase 1 trials take a medicine that's commonly just being explored in the laboratory, and now we see that it looks very, very interesting. It looks like there should be some very good activity, and we take it into human beings. And this is called a safety trial. Phase 1 is always looking at the safety of a medication in human beings. And it's a safety trial because we have no idea what's the correct starting dose. We have some idea what the side effects are in mice, but as you know, humans and mice don't always have the same side effects. And so we start at a low dose and we slowly work our way up, looking at safety checks along the way, making sure that the drug is tolerable. We look for the right dose, and we also look to see what the toxicities are or the side effects are. Once we identify the safety dose in a phase 1 study, if this medicine looks very interesting in a particular disease type like melanoma, we then can take it into a phase 2 study. So in a phase 2 study, we take a medicine, we know the right dose, and we know the expected side effects because we've already done this in our phase 1 study. And so a phase 2 study really looks at efficacy. Is this drug really as good as we think it's going to be in this particular tumor type? And if it is, we then say, wow, should this now be the new standard of care? Should we go to the FDA and say, this is the best drug that we possibly have for this particular cancer? And so how do we do that? Well, then we move on to a phase 3 study. And a phase 3 study is a comparative study that takes your experimental phase 2 drug and compares it to the standard of care treatment. So these are 2 completely different treatments. Patients don't get to choose whether they get the standard therapy or the investigational therapy. Doctors don't get to choose it. It is a completely randomized trial, which means with a flip of the coin, a computer is going to say, subject number 2 is getting the standard of care. Subject number 3 is getting the investigational therapy. And that is the fairest way that we can really assess, is this new medicine better than what we have as our gold standard. And depending on the outcome of the study, either our standard of care or gold standard therapy stays because it still is in fact better, or our new investigational therapy really does prove itself to be better than the standard therapy that we have. And now we have a new standard therapy that gets FDA approved. And that's how drugs come into FDA approval and are available to patients. So as you can see here, it's not a matter of, oh, we're going to take a drug from the lab and bring it to the patients and get it FDA approved in a year. Most of the time, from the concept of the drug coming into humans to the time that it is FDA approved, if it's FDA approved, can take anywhere from 5 to 10 years. So this is why when we look at things, it's an opportunity for you because that drug, if it's approved, may not be available for several years. So how does research work? Well, research works by us asking a question. We look at our population, which in my case and Dr. Wolchuk's case would be melanoma patients. And what's the question that we're asking? Are we asking a question regarding efficacy? Are we asking a question regarding pain? Are we asking a quality of life question? Depending upon the question, depends upon how we work with our statistics colleagues in order to design a study. So the study plan is based on a statistical model so that when we get results in the end, those results will provide us with meaningful information. And then we sit and we write the study based on the statistical model. And then we start to accrue patients. And when we put patients on study, we follow them very closely. There are specific inclusion and exclusion criteria. So what's the patient population? What things must they have? What things must they not have to be included in the study? And then we follow very closely and we do measurements along the way. If it's a pain scale, well, then every certain amount of weeks, we're going to provide patients with a questionnaire regarding their pain. They're going to answer it, and we're going to file those results into a computer. So when the total number of patients for our study gets enrolled, we can then look at the data, make our assessment, and make a determination. Was drug X effective? Was drug X not effective? Was pain improved? Was pain not improved? Was treatment effective? But look at the side effects that we caused patients. And it's through that very meticulous compilation of data that we can then move drugs forward and improve outcomes of patients. So when you participate in a research study, there are multiple different parts of a trial that you will be asked to read. And so I want to go over those so you understand what they are. The first is the rationale. Why are we doing this? What are our objectives? Meaning, what's the goal? What are we looking to prove by doing this study? The study will then provide you with background information. This is a melanoma study. Melanoma is a cancer of pigmented cells. You have, let's say, stage 4 melanoma. Stage 4 melanoma means that you have melanoma that has spread outside of the skin into different body parts. We then look at the study design. What is going to be required of you to participate in this study? How often do you see the doctor? How often do you get scans? How often do you get medicines? And what are the other study designed, study required tests that you need to have done? We then talk about our target population. So we talked about this a little bit on the slide before. What are the things that patients need to have to participate? And what are the things that patients can't have to participate? So for example, sometimes we do studies in untreated patients. So if a patient has already received an immunotherapy drug, they would be excluded from that trial because that particular trial was looking for patients who had never received therapy. To the converse, we have many studies that are looking at patients that have had treatment. So if you're just newly diagnosed with melanoma and you want to participate in the study, the answer is, well, you haven't had any treatment. So we need to provide you with a different treatment option or a different clinical trial based on the fact that you've had lots of therapy, and this particular study wants patients with no therapy. A study calendar is exactly that. It lays out what the study requires from you as a patient. What blood work do you need to have done? How often do you need to see the patient? How often do you need to see the doctor? Do you need to have a biopsy? How often do you get scanned? It then talks about how we store the drug. What are the side effects? And that's toxicity assessment. We're going to lay out what we know are the expected side effects and how bad are those side effects? Are they mild? Are they moderate? Are they severe? And then we talk about supportive care. And supportive care is essentially, what are the things that we can do to make you much more comfortable and help you get through if you have any toxicity? So to me, these are the questions that I like to have my patients ask me when we discuss a clinical trial. So the first is it a trial where we're looking at one new medicine, or are we adding a new medicine to an already approved treatment? Is this a non-FDA approved medicine? If so, what are the expected side effects? What are my potential benefits? What are my potential risks? What's my time commitment? Because depending upon trials, some trials are quite easy and you see the doctor every 4 weeks, and amen, that's the end of that. But there are some trials which are usually phase 1 studies because they are safety studies where it is a much bigger time requirement. And we do have to see you either once or twice a week for the first 6 to 8 weeks. And so you need to know that if you participate in this study, this is what we're going to ask of you. Also, if you're going to participate, is your transportation, your parking, your subway, your time going to be reimbursed by the study sponsor? And so that's something important for you to know as well. And many times we will just volunteer that information to patients and say, you know, we're going to take your receipt, you're going to give us your receipts, and then we're going to reimburse you at least for your commute or your parking. During the study, it is very common for people to have questions. And so you want to know, who do you call and how do you get in touch with them? For younger patients, it's also important to know, will this medicine affect my fertility? Because even with patients who have stage 4 disease, many times we are now curing our patients that are going to go on to live normal, long, healthy lives and may want to have a family. So that's a very important question that gets raised with anyone who is of childbearing potential. Ask about where else this trial is being done. What are my other options? Is this the only study? Is this my only option? What is the standard of care? You really need to do your homework before you embark on a treatment plan. If you decide to participate in a clinical trial, we then have to go through a process called informed consent. An informed consent is essentially a legal document that lays out everything about the study. So you know all of the potential benefits, you know all of the potential side effects. And we also make patients very aware that you could decide you want to participate in a research study, and you can change your mind at any time and say, you know what? Yeah, I just don't want to do this anymore. And it's okay. Just because you sign an informed consent does not mean that you are bound to complete the study. If you get the medicine and you don't like how the medicine makes you feel, you can always withdraw consent at any time. And it's always important for patients to know that and feel comfortable with that information. And yes, you can go on this study, and this study may be the cure for you, and you're going to want to stay on the study. But if at any point in time you change your mind, you need to know it's okay to change your mind, and also know what the alternatives are, so that if you decide that this is not for you, you know what your other options are. So now you've signed your informed consent. You say, okay, doc, I'm ready to go on to the study. So that would then put you into what we call our screening period. A screening period is from the time that you sign consent to the time that you start your actual first dose of therapy. And so during that screening time, we check your labs, we send you for scans. If you need procedures done, possibly a biopsy of your tumor, all of that gets done in, quote, the screening period. Once that is all done and you meet all of the study criteria, you then are told when you're going to start treatment. Okay, so what happens during the trial? Well, you get your study medicine, and then you're going to be followed very closely by your research team. Your research team normally encompasses the doctor, a research study nurse or a research study nurse practitioner, and your data folks. Most of the time, patients don't know who the data folks are, but these are people who work very hard behind the scenes to take all of the information that's placed inside your electronic medical record and put it into an electronic data form. So this way, at the end of the study, all of the data from all of the patients is completely blinded, and we can analyze it so that we can determine whether this therapy is effective or not. During the study, we're going to talk to you about what medicines you're taking. Are you having any side effects? If there's any changes to the study, we may ask you to reconsent if those changes impact the study significantly. And essentially, there's lots of things that go on, and you're very, very closely monitored when you participate in a research study. So what happens after the study? You get your treatment, everything goes well, the study treatment ends. Well, we still continue to watch you. We follow you for a designated period of either 30 to 90 days to still assess for any side effects. Many times we will ask you if you are willing to stay in follow-up. So what does that mean? It means that every 3 to 6 months, you're going to get a phone call from the study team saying, hi, we're just calling to see how you're doing. That's it. Yeah, I'm doing fine. That's great. Thanks so much. We'll talk to you again in a few months. And this is so that we can show this long-term survival and have long-term data on our patients that participate in studies. So you might ask me, well, then why don't more patients participate in clinical trials? And the answer is because most of the time, doctors don't talk to their patients about participating in clinical trials. 60% of patients said that nobody ever talked to them about research studies. 15% of patients were offered a study, but they were not found to be eligible. 13% decided, yeah, I don't want to participate. I would rather have standard of care. And a very small percentage did not have insurance coverage for care. But again, those are patients that may participate in research studies as long as they have coverage, whether it be Medicare or Medicaid. Even patients who don't have insurance may be eligible to participate in some of our studies. But that's a one-on-one discussion with the doctor as well as the sponsor. So why don't doctors talk about clinical trials? Well, because it takes time. Just like I spent roughly the last half hour talking to you about research studies in general, it takes just as long, if not longer, for me to sit and go through the nuances of the clinical trial that the patient is going to participate in. I need to talk to patients about the medicines, about the side effects, about the study calendar, about the time commitment, about things that they need to do. And so doctors in very busy clinics will say, well, it's just easier for me to talk to patients about the standard of care because that can take me 5 minutes, whereas getting a patient to consent to a research study can take anywhere from 30 to 60 minutes. Doctors are also worried about losing patients. You know, I'm fortunate enough to work in an academic institution where part of our academic mission is to improve the quality of care and push that needle forward. And so it is our goal in academia to put people onto clinical trials and provide them with cutting edge therapy. And so I don't really look at the clock when I see patients. I look at the patient, and whatever time you need is whatever time you get. And whatever treatment is the best treatment option for you is what we're going to decide together. And so this is really why a lot of other physicians may not talk about clinical trials. And some docs who don't do research really truly believe that standard therapy is always the best therapy. And that's not completely true. So we know that clinical research changes lives. We've seen it in melanoma because over the last 20 years, Dr. Wolchuk demonstrated how patients with stage 4 disease had a very dismal outcome in the year 2000, with only 5% of patients surviving 5 years. And now here we are in 2023, and patients with stage 4 melanoma can even be cured of their melanoma. So it's only because of clinical research that we have that wonderful statistic. So I think with that, I thank you for your attention. Hopefully I've made understanding clinical trials a little bit clearer for you. And thank you for your time.
Thank you so much, Dr. Pavlik. And we do have a couple of questions here. Someone is asking, how often do studies move to stage 4?
Okay, so I'm going to answer the question the way I think so there are 3 phases. There's phase 1, phase 2, phase 3. Phase 4 studies are looking at already FDA approved drugs. So many of us don't do phase 4 studies. If you're talking about moving a drug from the lab into a stage 4 patient, well, that really depends upon the drug activity. So it's really hard to answer that.
And then the same person, I think, just had some questions about, the thought process behind how trials are named in general, and why they're in all caps, which I'm sure is just something people wonder about. And I don't know if there's any particular reason why that is.
No, I think it's really just whoever types it up that way. There really is no reason for all caps. Why are they titled the way they are titled? Usually, again, if it's a phase 2 study, it's going to be titled a phase 2 clinical trial of drug XYZ in metastatic melanoma. If it's a randomized phase 3 trial, it's going to say this is a randomized this is a phase 3 study comparing drug X to drug Y in metastatic melanoma patients. And so really the title should really reflect the phase of the study it's in, the disease entity type that it's looking at, and what drugs are being explored.
Okay, perfect. Thank you so much, Dr. Pavlik. That was so informative and so helpful. And I will turn it back over to you to intro our next speaker.
Okay, so I'm going to take off my melanoma
Can I, sorry, jump in with one more question?
Yes, sure.
Oh, can you see me? There was a question about where can people find trials? And I indicated to that question that they can go to our clinical trial finder. And there's also clinicaltrials.gov, but I wanted to see if there were any other places that people can go that you would suggest, any sort of NCI designated places or anything on Cornell's website.
Yeah, if you're looking for a trial anywhere in the country, clinicaltrials.gov is always, that's where every clinical trial is listed. If you're interested in clinical trials at a particular institution, you can go to their website. If you were looking for a clinical trial at Weill Cornell, you can go to our Weill Cornell website from Meyer Cancer Center, look at clinical trials, and then you could type in melanoma and your trials would come up. But the broadest, and again, looking at Melanoma Research Foundation, that's going to really target down those trials to melanoma trials. And certainly going to your website is another great alternative for patients as well.
Thank you. Yes, and we do have a navigator ready on call for if people want to kind of talk through what that process looks like and how to get in touch with a specific clinical trial. So definitely reach out if you have further questions on clinical trials. But thank you, Dr. Pavlik.
All right. So again, thank you everybody for your attention. We're going to move on to our next speaker, who is Stephanie Wright. She is our registered dietitian who is going to speak to us about a very important topic that patients ask me about all the time, which is nutrition and cancer. So Stephanie, if you please, the stage is yours.
All right. Hi, everyone. I'm just getting my video started here. And thank you to the organizers for having me here to talk about nutrition. It's been really interesting hearing more about melanoma from all of the talks earlier today, and I'll hopefully shed some light on how nutrition can also play a role. Now, the overview of my talk today is going to focus on a couple of different areas. I am a dietitian working specifically in oncology. I'm a certified specialist in oncology nutrition. So every day I'm talking to people with different types of cancer, including melanoma, who are getting various treatments. So everything ranging from chemotherapy to immunotherapy to radiation therapy, and nutrition can have really big impacts. So we'll talk generally about the nutrition and cancer connection and how nutrition can help with that. I'd like to highlight a couple key nutrients that we want to think about specifically with melanoma, and then also talking more towards the end of the talk about the importance of fiber and its potential impacts on what we call the microbiome. And then we'll finish up with some takeaways just about what we learned about nutrition for the talk. Now, nutrition is providing our body's main source of fuel. So one of the things.
Yes, I can hear you with no problem, and you should have control of your screen.
Okay, perfect. So let me just switch back to the previous slide that I was on. Okay, so I was just talking about the importance of maintaining good nutrition status to help prevent muscle loss and maintain strength during cancer treatments. And the important thing about food is it also is a source of cancer-fighting nutrients. So components of plant-based foods in particular, a lot of the colorful pictures on my slides today are rich in what we call antioxidants and phytochemicals. And these are compounds in food that help our body cells to repair damage. So they can be very important when we're looking at a diet to help reduce cancer risk and also when you're undergoing cancer treatment. Okay, so why are we talking about nutrition specifically in the context of melanoma? Well, we have a lot of good research showing that good nutrition status during any type of cancer treatment can actually help a lot with improving the quality of life for patients. We also see that people who are maintaining their nutrition tend to have increased tolerance to treatment regimens, less unintentional weight loss, and also improved healing after a surgery. There's increasing evidence and research being done looking at a potential role of nutrition with melanoma, specifically some recent studies that are looking at the benefits of a higher fiber intake. So I'm going to discuss some of those later on in the presentation as well. And then another important reason that we want to focus on nutrition is that we know that cancer treatments can affect nutrition status. So there are common side effects that might be such as decreases in appetite that can make it hard for someone who's going through treatment to eat. I have a lot of patients who complain about taste changes where foods that they used to like don't quite taste the same, and that can sometimes make it hard to eat. Also, some treatments might cause digestive issues. So someone might be experiencing colitis causing diarrhea, or maybe experience some nausea with their treatment. And so there are ways that we can adjust nutrition and what someone's eating to try to help with managing those side effects. Now, malnutrition is a term that we use to define when somebody isn't eating well and it starts to affect their body in different ways. So there are different criteria that we use to define malnutrition, and some of them are unintended weight loss, not eating enough or having a decreased food intake, and also a loss of muscle or other body mass. And this can happen to anyone at any point. Sometimes it can happen prior to a diagnosis of cancer. Other times it's going to also happen during treatment if someone has a lot of side effects. Now, if malnutrition continues without any intervention, we see in studies that people have higher rates of fatigue and also decreased mobility. Also, we see more treatment delays, so someone might not be ready for the next dose of their treatment in time, which can impact outcomes. We also see people who are malnourished might have more toxicities from treatment, so more side effects, which again can make it hard to get that next dose. And then over time, if malnutrition continues, it can actually lead also to other effects in the body, such as impaired immune function, which is something that we really want to maintain for anyone with a diagnosis of cancer. So preventing malnutrition really is key during treatment if we can. If you're already experiencing signs of malnutrition, just intervening to try to prevent that progressing and maybe building back a little bit of strength. So working with a registered dietitian is a really important task at that point, because we can help you with ways to improve your nutrition. So the overarching goals of nutrition during any type of cancer treatment is to prevent that unintentional weight loss. Really at the heart of that is we want to prevent loss of muscle. We saw all the benefits of maintaining good muscle status, and so we want to help you feel your best during a treatment. We also see that we can reduce treatment-related fatigue in a lot of cases if we're having somebody that's eating adequately. So it's another big goal, is just making sure that that's not contributing to the fatigue that someone might experience during treatment. And then if you are having digestive effects, one of the big goals that we have is also to make sure nutrition isn't adding to that either. Now, the optimal diet during treatment can really vary, and so I put a lot of different examples up here of possible diets that we might recommend you follow in the spectrum of a cancer treatment. So it highly depends on the individual, somebody's preferences, maybe the food allergies, what cultural foods are important to them. It's also going to depend on side effects. So if somebody is having any changes to appetite or digestion, it might change throughout treatment. So we might suggest, for example, someone having colitis as a side effect, follow a low fiber diet. We might suggest someone who just had a surgical resection to eat a high protein diet. Someone with a low appetite, we might say, oh, we suggest you do small frequent meals to really build up more calories and get more strength back. So there's lots of different examples, and sometimes, someone might come in with already some dietary restrictions from other medical conditions that they have prior to diagnosis of melanoma. So working with a registered dietitian to give you some individualized advice can also be really helpful when that happens. Now, for anyone who's just looking to reduce their cancer risk, or for someone who is receiving treatment but isn't necessarily experiencing any side effects that impact what they're eating, then we do recommend a dietary pattern that we refer to as the whole foods plant-based diet. Now, what I like about this, and I have a couple images here from the American Institute for Cancer Research, is that it's not an overly restrictive dietary pattern, and it's pretty flexible. So it can be adapted to people from different cultures, and it can be adapted to different types of cooked dishes or raw dishes. The general idea is that you want the majority of the foods on your plate to come from plant sources. So in these examples, you can see that AICR recommends about 2/3 of your foods coming from plant-based foods, such as grains, fruits, vegetables, nuts, seeds, beans, legumes, and then you still have room on the plate for 1/3 of animal proteins or other animal-based foods like dairy if you're choosing to also consume them. When you're pairing foods this way, you're going to end up with a diet that's very high in fiber and very high in antioxidants. And studies have shown that diets that are rich in these antioxidants and anti-inflammatory compounds also can have been shown to reduce the severity of cancer-related fatigue. So we see that something like this is both important to reduce cancer risk, but also it can be very helpful to someone who's going through treatment if they're tolerating it well. Now, probably the most common question that I get every single day is this question that I think people hear a lot online or from well-meaning family members and friends is, does sugar feed cancer? And it's really not a simple question, but I think it's important to think about how sugar is used in the body when we consider that. So sugar is the main fuel for all of our body cells. So when we eat something that contains carbohydrate, it's going to break down into simple carbohydrates such as glucose. And cancer cells also, just like all of our healthy cells, also use glucose in a lot of cases, but they can also use other nutrients and sometimes will even change the types of fuel that they use. So the human studies we have right now currently don't support completely avoiding sugar in the diet or avoiding carbohydrates, which do break down into sugar. And simply by restricting sugar in the diet, we're not going to preferentially choose where the sugar is going to which cells. So we want to avoid malnutrition, as I mentioned earlier, which is something we have a lot of research showing can impact outcomes to treatment. So if we're limiting the diet too much and being restrictive, that can actually lead to malnutrition and might not have a great effect. Many carbohydrates also have a lot of beneficial nutrients, such as fiber and some of these other components I've been talking about, antioxidants, minerals. So we don't necessarily want to leave those out either. Now, there are different types of sugar in the diet. So added sugars are sugars that are more from a refined source. So that's going to be something like granulated sugars, different types of syrups like maple syrup, honey. And these are going to be things that are typically added to foods. So they're isolated down and added to sweetened foods. They tend to have limited nutrients. They're mainly a source of energy. Some of the syrups, like honey, are going to be a source of trace minerals, but generally they're mainly an energy source. Now, natural sugars would be carbohydrates that do break down into sugars. So examples of these would be fruits, whole grains, starchy vegetables. And these are the ones that contain a lot of beneficial nutrients in the body, such as the vitamins, minerals, and antioxidants. Now, we do have a new nutrition label within the last few years where you can actually see the added sugars that are on a product. So in the United States, the leading sources of added sugar in the diet does come from sweetened beverages. And then that's followed by sweet treats like desserts and also processed or ultra processed foods where you might not even expect there to be added sugars in that meal. So this example, you can see where it has the number 2. It's showing you exactly how many grams of added sugar are in a serving size of a product. So in this particular example, 8 ounces of a sweetened beverages has 23 grams of added sugar. Now, we do see that there can be a connection with consuming excess added sugars and chronic inflammation. And I put excess in bold because This relationship that we're seeing is in studies where people are reporting high consumption of these sweetened beverages and foods that contain a lot of added sugar. It's not talking about someone who's having a piece of dark chocolate or an occasional sweet treat. So it's really over time when people are eating excess of foods that contain a lot of these added sugars. So we have an indirect link between excess sugar over time and chronic inflammatory conditions like cancer. So we do have guidelines for, keeping the added sugar intake to a safer level. So the American Institute for Heart the American Heart Association does have guidelines for added sugar intake, which you'll see their infographic on the screen here, mainly looking based on calorie limit, about 9 teaspoons for men and about 6 teaspoons for women as the maximum per day. That's limiting to about less than 6% of total calories. But when you look at a label, you're going to see that added sugar in grams. And when you look at teaspoons, that would be, say, if you were adding a teaspoon of honey to your tea, then you see you can be well within the safety guidelines that we have. And I think this is important to know that this is only talking about those refined sources of sugar, and it's not talking about anything like fruit or starchy vegetables or other things. Now, some additional tips for enjoying sweets is learning to read the nutrition label so that you can keep that portion of the sweet item within the recommended guidelines for that daily intake. Also, choosing unsweetened beverages. We know that that's the biggest source for people in the United States. So if most of the time you're choosing to hydrate with unsweetened beverages, that can be a really good way to limit your added sugar intake. You can also try to have more whole foods that have a naturally sweet flavor. So I'll often recommend this to people who are looking to reduce their intake from added sugars. So maybe having a snack of something like dates with peanut butter. Not only are you going to get the sweet flavor, but you'll also get the added benefits of the fiber and the protein. Similarly, dark chocolate tends to be lower in sugar, and it also is rich in magnesium and antioxidants. And then another example might be yogurt with honey, where you're getting protein and calcium along with the sweet flavor. Now, next, I'm going to highlight a couple important nutrients that I commonly will talk about with patients. And one of the most important is protein, just because we saw how many benefits you have when you're maintaining good muscle mass in the body, and protein is going to be the basic building blocks for the muscle in your body. So that's important to maintain the muscle mass that you have, or some people might be trying to increase their muscle tone to increase how strong they're feeling. Also, we recommend people who are experiencing fatigue to eat protein more often throughout the day, just to help support their energy levels. Also, it's a main building block for a lot of your body cells as well. So there might be certain treatments such as surgery or radiation where your body might have even higher needs for protein. So we always address and make sure that somebody is getting good sources of this nutrient. Now, it's found both in animal and plant-based foods. So depending on someone's preferences or digestion or what they're tolerating, we usually recommend a mix of different proteins that someone likes, just to make sure that you're getting all of the basic building blocks from these different foods. So I've listed a couple examples here. And certainly if you're not sure what your specific protein need is, you could certainly work with a dietitian to figure that out as well. Now, another nutrient of interest that I wanted to talk about today was vitamin D. And vitamin D is a unique vitamin in that the majority of what we get is actually not from the foods that we eat. So we mostly get our vitamin D from synthesis on the skin with exposure to UV light. And we've heard a lot today about the importance of controlling that environmental risk factor by protecting ourselves from too much sun exposure. So from the diet, we're typically only getting 10 to 20%, and a lot of the foods that are high in vitamin D are listed here. So it can be hard for someone who is controlling their exposure to sunlight to meet the vitamin D needs fully from foods alone. So this is a very important vitamin for immune function, and there's been a lot of research showing its importance as well with potentially reducing cancer risk. So what I recommend for people that have to greatly limit sun exposure is to have your blood level checked sometime when you're at the doctor getting lab work done, because we can actually see whether your level is low, whether your level is optimal. That's the best way to kind of assess if you might benefit from a supplement, or maybe you're getting enough from the dietary foods that you're eating. Optimal levels for melanoma are not specifically defined, but in the general population, we usually want that number to be above 30. So again, you can always ask your doctor if it would be appropriate for you to have a vitamin D level added on, and then you might need a supplement depending on whether that level looks low or not. It's also important to make sure that you're not taking a supplement that's too high of a dose without having levels monitored. Vitamin D is what we call a fat-soluble vitamin, and those particular vitamins are stored more in the body. So you have an increased risk for having too much vitamin D or toxicity. So I don't typically recommend people take high doses of vitamin D long-term without having that level checked. So that's another important point when considering this vitamin. Now, fiber is the last nutrient that I'm going to talk about today, and we know fiber comes from a lot of those whole foods that I was talking about before, and it has a lot of important roles in the body, such as maintaining regularity, increasing satisfaction with meals, regulating blood sugar. And we also are starting to see recently a lot of research being done on what's called the microbiome. So the microbiome is a collection of microorganisms that are associated with the body, and a lot of them are found in the digestive tract, so kind of lining your whole digestive tract. We know that in people that are eating more fiber or more diversity of fiber will have a more diverse microbiome. But it is important to note that what we eat is not the only thing impacting the microbiome. So we know that there's a lot of other environmental factors, medications, someone's genetics that can also impact the microbiome. But it's exciting to see that there's sort of a modifiable one from what we eat that can also make changes to this microbiome. Now, we know that plant foods are rich in fiber, and when we have a diverse microbiome and eating these fiber-rich foods, they're actually going to be feeding the bacteria in the microbiome, and we get what's called a metabolite that's formed in that process. So metabolites, you might also hear them referred to as postbiotics, seem to have a pretty positive effect in the body as well. So studies show that they might help improve anti-inflammatory responses in the body. They certainly help with improved motility from what we know about fiber so far. And they also might help with protecting against infection, which is also a pretty important benefit in this population. And then interestingly, there's been some research happening in melanoma patients specifically. So a couple years ago, there was a study published in the journal Science that was looking at patients specifically who had advanced melanoma who were receiving immune checkpoint inhibitors. They had them complete lifestyle surveys to try to assess what their baseline dietary habits were. And part of what they assessed was looking at their fiber intake and also looking at their use of probiotic supplements. Now, it is important to note that this wasn't by any means a causative study, so they weren't doing an experimental design where we can show causation. But what was really interesting was they found that there was an association between people that were eating sufficient amounts of fiber and the immunotherapy response. So every 5-gram increase of fiber intake that people reported was actually associated with a lower risk of progression-free survival for people that were receiving these treatments. So it's really interesting findings, and I think with what they found in those studies, there are actually a few clinical trials that are actually looking at this in an experimental design just to see if we, kind of increase that fiber intake, can that provide more benefit for someone getting these treatments? So we don't necessarily have the answer to that yet, but the good thing about the sufficient fiber intake is it's already what we recommend for reducing risk for cancer and for anyone who has had a diagnosis of cancer. So both the American Cancer Society and the American Institute for Cancer Research both recommend this higher fiber diet. So I think it's only potentially showing additional benefit to that. So just some interesting data that we have in the melanoma population for that too. Now, how do you get enough fiber? I wanted to talk a little bit about that. So the best sources of fiber are going to be from things like whole grains, fruits and vegetables, especially those that have the skin intact. Those are going to have more fiber. Beans, lentils, legumes. So those are a great protein source that can help you increase fiber as well. Nuts and seeds, great snacks that also have a lot of fiber intake in them as well. Now, the recommended intakes are to get at least 5 servings of fruits and vegetables every day. And depending on the person, we usually recommend anywhere from between 25 to 30 grams of fiber per day. In the study that I went through previously, what they considered to be sufficient fiber intake was actually even a little bit lower than that, which was about 20 grams of fiber per day in that immunotherapy study. So just to kind of get a sample day of what it looks like to eat a high fiber diet, I just wanted to include some visuals and pictures of what that might look like. So you can see these meals were including whole grains like oatmeal, nuts like almonds, and fruits especially that have the skin like blueberries. Lunch, we have a high fiber food from the black beans. You can choose different types of grains. If you're choosing a whole grain, that's going to be another way you can further increase the fiber. And then grilled vegetables in this example to really increase the fiber there. And then for dinner, maybe having fish for protein and a couple of cups of salad that's going to help add fiber. And then if you're having something like potatoes or sweet potatoes, if you leave the skin on, that's only going to increase your fiber intake as well. And not every meal is able to be high fiber, sometimes might be on the run. It might be hard to get enough fiber intake. So having fiber-rich snacks can also be another good way to help increase your intake. So snacks like trail mix or fruits and nuts, whole wheat crackers with dips, and cut up veggies with hummus can also be really helpful ways to kind of up your fiber intake over the course of the day. So takeaways, understanding that nutrition needs might change during a cancer treatment process. So it's okay if your diet is not high fiber 100% of the time. If there are certain things that you're not tolerating that well, there might be a time where we ask you to not follow that typical recommendation, and that's okay. We want to treat and prevent malnutrition with good nutrition and exercise to help maintain good muscle tone. So that's something that's very important for anyone, no matter what type of treatment they're receiving. Also want to incorporate, if you're tolerating them well, plant-based whole foods for additional fiber. And if you're not sure, how to incorporate this in your lifestyle, or you just have other questions that you think go along with this, then meeting with a registered dietitian for guidance can be very helpful as well, especially if someone is certified in oncology. They have a lot more experience that could be helpful with that as well. Here at Cornell, patients that are getting, infusions or treatments in our centers do have complimentary nutrition services available. But if you're receiving treatment somewhere else, you can also ask your doctor for a nutrition referral and find a dietitian either locally or someone who's able to provide you with virtual guidance. So with that, I'd like to thank everyone for listening and see if anyone has any additional questions I can answer.
Thank you so much, Stephanie. Yes, we do have a few questions here. Someone is asking, is it important to have protein in every meal?
Yeah, so great question. Thank you for that. I think protein is something that if we have someone that has an increased need for protein, typically the easiest way to meet that high protein need is going to be including it at every meal. There might also be other reasons we could suggest that. So it does become a little bit of an individualized question. But that being said, not every meal is going to be perfectly balanced. And so maybe you'll have a meal that's a little bit lower in protein. The body can still utilize a larger source of protein at a later meal in the day. So you absolutely could just make sure you're meeting your protein needs in other meals that day if you're having a lower protein meal.
And then someone else was asking, do beans provide complete protein?
So a lot of plant proteins, what we define a complete protein as is something that has all of the essential building blocks of protein, which are called amino acids. So animal proteins are complete sources of proteins. Some plant proteins don't contain both. So beans, for example, are lower and missing some of those, but when you're eating a meal, you're generally getting other foods alongside that will help make it a complete protein. So for example, beans and rice together, you're going to get a complete protein that way. Also, there's, research suggesting that it doesn't even have to be within that same meal. So maybe you're having a bean-based meal and a couple hours later, you have something that has rice in it. That combination is still going to be beneficial. So, the focus on complete protein, I think as long as you're eating a diversity of foods, that's going to be the more important part, is just making sure you're getting enough protein. But it's a good question because animal and plant proteins can vary a little bit.
Perfect. Thank you so much, Stephanie. That was so helpful and so informative. And I'll turn things over to Dr. Pavlik.
Okay. Well, thank you, Stephanie, really for a really terrific talk. I think that was really so helpful. And last but not least on our agenda today is Dr. Guy Meitel from Our Supportive Services talking about coping with uncertainty. So I'd like to turn this now over to Dr. Meitel.
Thanks so much, Dr. Pavlik. Can you hear me okay?
Yes. Yes.
Except my video just went off for some reason. Let's see, can I do this?
There you go. Now we can see you and we can hear you. Perfect.
Pardon the blue halo. Usually I can zoom in on my camera, so we'll just have to include it. Something changed with the settings. But it's great to be here, and thank you for the opportunity to share with you some thoughts. Given that this is the last talk of the day, I figured I would be somewhat less formal, but hopefully informative. So I am a psychiatrist. I'm a psycho-oncologist and a clinical professor at Weill Cornell, and I've been a psychiatrist practicing in this area for nearly 20 years. And I'm also the head of psychiatric services for Forge Health, which is a company that provides mental health services for people in general and for those who are dealing with cancer either directly or are the loved ones or a caregiver of people dealing with cancer. Now, how do I advance the screen? Oh, it's really small. I see. Okay. And other than what I've just said, I have no financial disclosures. So here's what I'm going to do. I'm going to start with the general overview and talk about a topic that I think would be relevant to you regardless of where you are in your cancer journey. Either you're the person who's dealing with melanoma or you have a loved one who is. But to start off with some numbers, obviously, I'm an advocate for behavioral health care and cancer. 1 in 3 people with cancer experience mental or emotional distress writ large. And in terms of formal diagnoses, in melanoma, the prevalence of depression ranges from 6 to 16%. That's 1 in 20 to about 1 in 6. And then in terms of anxiety, anywhere from 7 to 30%. This actually is from a very large meta-analysis from this year that looked at studies that included over 12,000 patients dealing with melanoma. But it's not simply people who have active illness that deal with psychiatric or psychological concerns. Up to a quarter of cancer survivors experience symptoms of depression, and nearly half experience anxiety. And then many also experience symptoms of post-traumatic stress disorder. And one fact that is little known in the community, it's people who are cancer survivors actually overall, not necessarily specific to melanoma, but overall are twice as likely to die by suicide than the general population. So wherever you are in the cancer experience, it's always worth considering, what sort of support or supports do I need? And here's the thing about cancer. The thing about it is it comes in the midst of life and it takes over everything. There is just all the different worlds and aspects of our living, regardless of where you are in your life. And then when you have a diagnosis of cancer, it's pretty all-encompassing. And then the question is, how do you continue to live? Because most people literally cannot stop everything and simply deal with cancer, even though that's what's often expected, including by ourselves. And because cancer is abrupt, it's unexpected, it means a lot of change. It's not something that's on anyone's bucket list. No one is planning for it, but there are things to deal with. There are the obvious physical changes, the decreased functional ability, fatigue, changes in sleep, all the physical symptoms that go along either with illness or with its treatment. And of course, pain is always a source of anxiety, even if it's not actually present, meaning the specter of pain. And of course, there are the psychological aspects. Obviously, anxiety and depression, I don't mean simply the diagnosis of, I mean the experience of having anxiety, feeling sad, decreased ability to enjoy things. The more pain you have, the more anxious and depressed you get. That is just a clear connection. There's the fear. There are lots of fears. And then there's even decreased in cognition or attention that, again, can go along with some of the treatments or with the disease itself. And then there's the things that are even less talked about, the social challenges, the financial burdens. For many people, cancer treatment, participating in cancer treatment costs them more than they have, literally. Or there's worrying about being a burden on, or if you're a caregiver, how do you function now that you have essentially a second job? And then there are issues around affection, sexual intimacy, changes in appearance, all of which are part of the experience to one degree or another. And then finally, there's kind of the big picture questions that some people struggle with around questions of how do I make sense of this? How do I deal with my existence in the scope of the greater scheme of things? And all of this is at play once someone says, oh, you have a diagnosis of cancer to one degree or another. So how do we begin? Well, when someone comes to seek help, we have to start somewhere. We have to actually figure out where you are. Here, and I do mean we together have to figure out where you are, because the trajectory is really different depending on where you are in your experience of cancer. Where are you in terms of prognosis? Where are you in terms of treatment? And then, of course, where you are in life. A diagnosis of melanoma at 80 is very different than one at 20. You're dealing with different things in your life that are directly impacted by the diagnosis and the associated treatment course. So that's one thing. Just where are you in terms of your life? And the second thing is, where are you in terms of the treatment course? And you could be anywhere on this graph, this chart, anywhere from the initial diagnostic uncertainty, coming in with a new finding, a new symptom, coming up with a plan once a diagnosis is made, then starting in treatment, reassessing the treatment over and over, depending on what you need, and then moving into either long-term illness, remission, or survivorship, or palliation and having terminal disease. And those two get reassessed over time. So depending on where you are here, you're going to be dealing with different things. Or if your loved one is wherever they are, you're going to be dealing with different things if you're their caregiver, because life is still happening all throughout. You still have bills to pay. If you have a job, you have a job to deal with. If you have children, you have children to take care of. If you have elders, you have to take care of your elders. If you have other responsibilities, you have other responsibilities. And that the cancer doesn't say, take a break. You have to figure out. And then there are certain psychological or emotional things that people often grapple with. Like at the beginning, who do I trust? I go for a second opinion and they say it's something different. Who do I trust? Or during the initial treatment phase, thinking about new roles, how do you reorganize life? Or how do I cope with symptoms that as the treatment progresses? Or how do I deal with the fear of recurrence once the treatment is, at least for the time being, complete? All of these are factors that people grapple with. And there are lots of ways to engage with that, but these are the sorts of issues we talk about and deal with when we're when you're in a clinician's office. And the last thing we look at, I'm just giving you how we think about these things, is there are lots of things that are happening simultaneously. So could there be a pre-existing illness, like you come in and you have been treated for anxiety for 10 years, and now you have something, quote unquote, to be anxious about? Could there be a neuropsychiatric effects, like is the treatment or cancer directly affecting the brain? Is this so-called clinical depression really just you're sad about a loss of a role, like you can't continue in your job, or you can't be intimate with your partner in the way that you used to be, or are you just having a really hard time dealing? And so all of this is included as well. And so I thought about what could be of use to you all, because you're obviously in lots of different places in terms of life, disease course, treatment, being a patient directly or a loved one of a patient. But there's one universal, not one, there is a universal that cuts across all of this, which is the world of uncertainty. Whether you're dealing with which doctor do I go with? Do I go with this treatment or that treatment? I'm in remission, but I have a PET scan coming up. What will that show? When do I tell my children? What's the right way to do that? All of these questions have uncertainty associated with them. And the trouble is, its uncertainty is a challenge, especially when the stakes feel very high. And we really do live like uncertainty is bad. Like more certainty is better than less. But the fact is, to be human is to be uncertain. We never have perfect knowledge of anything. Here are a couple of quotes from President John F. Kennedy: "There's nothing more certain and unchanging than uncertainty and change." Or the philosopher Voltaire: "Uncertainty is an uncomfortable position, but certainty is an absurd one." When stakes are high, especially when anxiety, fear, worry is there, uncertainty becomes very difficult to deal with. And I want to divide up these three terms so we can have a bit more clarity around them. See, uncertainty is a state or quality of not having certain knowledge. Straightforward, and we never actually do. Risk is the probability or odds of something bad happening. And anxiety is a feeling of worry, of nervousness, of unease, usually about something with an uncertain outcome. And these two get into a blender and get mixed up all together and makes it much more difficult to deal with each. So uncertainty is a state, risk is the probability, and anxiety is the feeling you have about that. Because it is part of the human condition to be uncertain. It actually is, in a funny certain way, if you want to live life like you actually have a choice, like you have free will, then uncertainty comes with the package. There's this great quote from the book, The Magician King, and it says, "I don't think the gods can change their minds. When you get to that level of power and knowledge and perfection, the question of what you should do next gets increasingly obvious. Everything is very rule governed. All you can ever do in any given situation is the most gloriously perfect thing. And there's only one of them. Finally, there aren't any choices left to make at all." You're saying the gods don't have free will? The power to make mistakes, Penny said. Only we have that, mortals. To be a human being with free will means there's uncertainty in the mix. And the question is, how do you tolerate it? How do you live with it? Maybe even dance with it. So here's this is almost insultingly simple. Okay. But it's kind of like, yeah, but how do I do this? Embrace uncertainty. Ask what is there to do it, and repeat. It's almost insulting, I know. And at its root, this is what we all strive for. So the question is how to do it. Well, the first thing to get is it really is part of, it's wired in, it's built into being human. It's part of actually the brain to be uncertain. And especially, let me be more precise, to be anxious about uncertainty is the brain doing what it does. Because the brain has one function, despite all of the glorious things that the human mind has accomplished. The brain's function is to survive. And for everyone on this call, it's worked perfectly. No one here has intentionally stepped in front of a moving vehicle, I hope. And that's what I mean. It works. Its only job is to survive. And so it is always looking to what it already knows to predict what's next. So if something new happens, the brain goes to look for what's similar to this that I can use to survive this thing that is, I think, is coming up as a threat. In other words, when people say, I'm afraid of the unknown, what they're actually afraid of is what they know. If it's truly unknown, then there's nothing to be afraid over. The anxiety comes from the brain not knowing what's the thing to do to survive. Normally, we live in mostly predictable lives, like you get up and you're not surprised by the reflection in the mirror. But when you get news or are dealing with choices that are unfamiliar and have high stakes and don't have a right or wrong answer, it's very tough. You see, it works really well as a prediction machine, except when there isn't a clear, this is what I should do and this is what I shouldn't do. You know, there's a cat, Shakespeare's cat is to be or not to be, then Schrodinger's cat is both. See, a lot of the decisions that have to be made around cancer, its treatment, whether or not to pursue care of a particular type are probabilistic in nature. You have 70% chance of doing well for 4 to 6 months if you pursue this course of treatment, and a 50% chance of doing well for 6 to 10 months if you pursue this treatment. It drives the brain batty because the brain is one question, am I going to survive this or not? And it wants to turn everything into binary decisions. And we have a hard time sitting with, well, I don't know. There is no certainty here. We do our best. But what it does is it brings this whole world of uncertainty from the background to the foreground, which is why it causes so much anxiety. And what happens is we feel like we're threatened. The brain literally goes into fight or flight mode, or freeze, actually. The truth is it's not fight or flight, it's fight, flight, or freeze, and most of us freeze. It's a rare person who punches someone when they get bad news. It's a rare person who gets up and leaves the room when they get bad news, or scary news, I should say. Most of us sit there and freeze. We don't know what to do, and higher order thinking shuts down at the moment when we need it most, because we're worried about being eaten. That's what the brain is doing. And the question in real time is, how do I allow myself to think a little bit? There's nothing you could change about this response, but how do I at least get that this is built in, this is predictable, and this is something I can do something about? In other words, how do you grant yourself space to be? Because on the one hand, sitting under a blanket is not terribly effective, even though it feels safe in the short term. And I mean that either literally or metaphorically, when we don't open emails, don't open mail, avoid phone calls, avoid medical visits, don't want to deal. It's a short-term way the brain uses to survive, and everyone here knows it's completely ineffective in the long term. On the other hand, this is pretty silly, you know. So the question is, how do you find some middle ground between head under a blanket and running recklessly head on into something? And that's where the thinking actually has to happen. That's where it's useful to take on some practices, to try out new things. You get support and you practice what you learn. You know, Bobby Knight, very successful college basketball coach, used to say everyone wants to be on the championship team, but nobody wants to come to practice. And by the way, practice, in case you're wondering, looks a lot like failing a lot. You don't get good at something without failing a lot. And you don't need to practice something that is innate. So the question is, what is it that you're going to practice? Well, you do what works for you. First of all, y'all are experts on you to whatever degree. You've been anxious before and you've gotten through it. What have you done? What's worked in the past? For some, it's talking with people. For some, it's getting information. For some, it's getting reassurance or coaching or mentorship. For some, it's being physically active where it's doable. For some, it's avoiding it for a while, which is actually perfectly fine. Practicing mindfulness. There are lots of things, whatever's worked for you in the past. See, the challenge for the brain is that there is no right or wrong in the world of probability.